Dr. Maheshwari, how are you?
Fine, sir.
Good, good, good. Good to see you after a very long time.
Yeah.
Yeah.
So, sir, we are live on the YouTube, so we will keep the conversation to the personal level. So wait for another 2 minutes before we start the session.
Good morning. Good afternoon.
Afternoon.
How are you?
Fine, thank you.
Hi, Matthew. How are you?
Good, good. Hi, sir. How are you?
Good
Namaste.
evening, Puri sir. Dr. Maheshwari.
Sound is not the problem. The sound is all cracking up.
My voice is okay. So that's an indication for me to keep quiet then.
So we are live on YouTube at the moment.
Right. Okay.
So we will start the program, which is 5:04 now, so 5:03. So we'll start the program. Dr. Shyam Sundar is here. So our President-elect, Dr. Gagandeep Singh. And we also have the coordinator, Dr. Maheshwari and Dr. Bansal here, and all the faculty is very much here. So it's indeed is a great pleasure for me today to kick off on the ongoing session of Freedom Series. The Freedom Series, which is a joint venture between the IAN and API, which was started on 26th of January this year with the first session. And I'm extremely happy that we are continuing. And today the 8th session is on the 15th of August. So it started on the Republic Day and continue on the Independence Day. So that self speaks about volume of this series, which is a very important collaboration between the API and the IAN. With me, Dr. Shyam Sundar, the President API is there. Today is a very special day, 75th year of independence to our beloved country. And as Prime Minister Mr. Modi in the morning mentioned that we all are celebrating Azadi Ka Amrit Mahotsav, so 75 years, and Har Ghar Ghar Tiranga. So obviously we had flag hosting in each and every house. Everyone is been very passionate and patriotic about the today Independence Day. I'm having a flag on my left chest, and also we had a very big program on Independence Day with help of people with epilepsy. So this is indeed a great moment, not only for us, because our country has past 75 years of freedom and we are getting independent. So that's a great pleasure. And with me is Dr. Shyam Sundar, the one who has taken the initiation further. And I'm sure this will go beyond the Freedom Series, will go beyond the Republic Day and the Independence Day and continue even in the future on all these occasions. Over to you, Dr. Shyamsundar.
Thank you, Dr. Surya. Indeed, it's a great day to have this Freedom Series. And I wish everybody a very happy and joyous Independence Day. It is very nice to have this program regularly. And as Dr. Surya said, it is a number of programs have been held on the monthly basis. And today's topic is neuropathies, which is actually very important. Every day physicians come across this, but it remains a puzzle. Hardly ever it is discussed in any of the fora, and not in API, I know. So I'm sorry, in IAN it would be discussed many times, but in API it is not. So I'm sure that both members of IAN and API will be immensely benefited by this lecture. And I wish every success to this program. Over to you, Dr. Surya. Thank you.
Thank you so very much. And President-elect Dr. Gagandeep Singh, who was previously coordinator for API program. And this series was started with both Gagan and Dr. Maheshwari, and Dr. Bansal has joined now to take it forward. So with may I request Dr. Gagandeep Singh to say a few words of the program which has been going on and about our 4 speakers who are excellent, and then you please invite Dr. Maheshwari and Bansal to take it further.
Thank you, Dr. Surya. Thank you so much for this, for putting up this, all of this together. And this is not just the first time and the only instance. I mean, there is such a huge number of web-based events which you have very kindly and with a lot of hard work and a lot of vision, you have actually put them up, and I think it just speaks volumes about your vision. I'm so particularly enchanted by the dynamic speakers that we have today, and I will actually not be introducing them. The organizers or the conveners for this activity, Dr. Maheshwari and Dr. Bansal would actually do that, but it would be a treat any day to listen to the speakers on this particular topic. As Dr. Shyamsundar very rightly pointed out, it is a topic which is not often discussed at great length, and however, it is extremely interesting, intricate, and as these speakers would tell us and lay before us the intricacies of peripheral neurology. I think we are going to be all ears, but thank you so much. With this, I request Dr. Maheshwari and Dr. Bansal. Is Dr. Bansal around? Yes.
Yes, sir. Yes, sir.
You're there. Fantastic. So please, the stage is all yours to take forward.
Thank you, Dr. Surya, Dr. Shyamsundar, Dr. Gagandeep Singh. Today's topic is very much important, peripheral neuropathies. And usually we miss out in our rounds, etc. And also from the physician point of view, that it's too much important when the patient comes with a paraparesis, with the quadriparesis or paraparesis. So it's becoming a very much difficult part at that point of time to have the differential diagnosis with the myelitis or other things. So not wasting out the time, may I invite Professor Matthew Alexander. He is very well known in neurology, and his topic is the approach to peripheral neuropathy. Sir, Professor Matthew Alexander. He is Professor of Neurology in Department of Neurological Sciences, Christian Medical College.
Thank you so much. I hope I'm audible.
Yes.
Yes.
Yeah. Thank you so much, Professor Nirmal Surya and the organizers for giving me an opportunity. The topic given to me, Namaskar and Happy Independence Day. We are in the 75th Independence Day, and we at this time we look forward and we look from where we came and where we are now and where we are leading to. It's an amazing country, and we really dedicate this symposium to the Independence Day and to the country. The topic given to me is approach to peripheral neuropathy. Now, this is Vesalius' slide of saying how many nerves are there in the body, the countless number of nerves. When you look at the lower motor neuron, it starts with the anterior horn cell. There's a ventral root. There's a plexus, bundle of nerves. There's a peripheral nerve. There's a myoneural junction and the muscle. So when you have low motor neuron involvement, you have profound weakness, muscle atrophy, hyporeflexia, flaccidity, fasciculations, and muscle cramps. Now, if you look at the scope of the lecture, we need to look what's the prevalence of neuropathy, the need for screening tests, a structured approach, laboratory investigations, pitfalls, and vignettes. So if you look at the prevalence of neuropathy, it's about 2.4 per 100,000. And when you look at individuals above 55, it's about 8 per 100,000. Diabetes is the most common cause. About 8% have neuropathy at diagnosis, and the increase in frequency with disease duration to about 30 to 60%. So when you approach neuropathy, you look at in the spatial concept. Is it a mononeuropathy? Is it a monoradiculopathy? Is it a peripheral neuropathy or a mononeuritis multiplex or a radiculoneuropathy? Then you look at the functional grades scales to find out, is it motor, sensory, autonomic? Then you come to the pathophysiology, and then you come to the temporal profile. Is it an acute neuropathy, which is usually within 4 weeks, like a Guillain-Barré? Then you have subacute neuropathy going up to 3 months, and then chronic neuropathy. That's temporal profile. So when you approach neuropathies, it's important to know what are the comorbidities. Is the patient on some medication? Is there an exposure to toxin? Is there a family history? You need a focused history examination and a good electrodiagnostic testing. Judicious laboratory testing, cutaneous nerve and skin biopsies. This approach in etiological diagnosis allows an etiological diagnosis about 76% of the cases. The question when you have a patient in your clinic is, does he or she have a neuropathy? What are the signs and symptoms? Is this a combination of motor, sensory, and autonomic? Because you know that the peripheral nerve has motor, sensory, and autonomic fibers. Very important to pick up mimics, because it's important to pick up mimics. And then to find out, is it a focal disease, a multifocal, or a diffuse disease? So if you classify neuropathies, as I said before, is it a mononeuropathy? Is it a radiculopathy? Is it a cranial neuropathy? Multifocal, like a polyradiculopathy, or multifocal motor neuropathies, multiple neuropathies, including plexopathies. When you look at the pattern of neuropathies, you look, is it a LEN-dependent pattern? If you have a nutritional or a metabolic one, you have a LEN-dependent pattern with a dying back phenomenon. Or is it a polyradicular neuropathy like GPS? Or a mononeuritis multiplex, where you have multiple nerves getting affected? Or patient comes to you in a confluent pattern where you need a nerve conduction study and EMG to confirm the spatial distribution and the asymmetry. So if you look at the pattern of nerve fibers, it could be sensory, motor, or autonomic. Large fiber includes motor, A alpha and A beta sensory. Small fibers are A delta and C fibers. They are autonomic, they mediate pain and temperature. There could be preferential neuropathies like small fiber versus large fiber neuropathies. Small fiber neuropathies could be a chronic idiopathic small fiber neuropathy. You can see them in diabetics. You may need bedside autonomic function tests to look for orthostatic intolerance and pseudomotor function. This is a patient where we do a look for orthostatic hypertension using a phenopress, looking at significant blood pressure fall, causing orthostatic hypertension, and or it could be a patient when they stands, calling postural tachycardia syndrome, where you have increase in the heart rate on standing up. So when you have a large fiber, you have an element type of weakness, loss of deep tendon reflex, and loss of proprioception. The differential diagnoses are DRG, Sjogren, paraneoplastic, toxic, idiopathic, B12 deficiency, sensory ataxic variant of CIDP, or IgM MGUS. When you do a nerve conduction study and needle examination, this is sensitive for large fiber sensory and motor. Both sensory and motor, pure sensory and motor neuropathies could be there. Routine electrodiagnostic tests are not sensitive to detect small fiber neuropathies. Hence, you need to do a sympathetic skin response. If there's a cardiac dysautonomic symptoms, you need a baroreceptor testing, cardiovagal, HR, and BP response to upright posture. If it's a small fiber neuropathy, you need a skin biopsy, you need a QSART and QST, which are more sensitive. So when you look at the temporal profile of neuropathies, you can have an acute neuropathy, a subacute neuropathy, or a chronic neuropathy. When you come to the pathology, you look whether it's an axonal neuropathy or a demyelinating, and you need to correlate with the nerve biopsy. Family history is very important because hereditary neuropathies account for about 40% of the neuropathies which are undiagnosed, which are not diagnosed early. It's under-recognized. You look for markers like pes cavus or kyphoscoliosis, predominantly motor neuropathy, so they may not have sensory symptoms. You need to screen family members, CMT1A, 30% of them are axonal. And this is going to be discussed later by my colleague. Very important when you have a neuropathy is to have a system review, general examination. Look for medical illnesses like diabetes, connective tissue disorders, malignancy, infection, malnutrition, exposure to drugs and toxins, chemotherapy drugs. Scenarios are very important. Clues from medical and family history, no specific findings to direct workup. Then you need lab workup based on the differential diagnosis associated with a particular neuropathy syndrome. So what are the laboratory tests? You need screening tests like CBC, serum electrolytes, renal and liver function tests, blood sugars, glycosylated hemoglobin. In many times, you may need a glucose tolerance test because many times you might have a subclinical diabetic neuropathy, serum immunoelectrophoresis. Use of batteries of lab tests and antibody panel without regard to the character of neuropathies to be discouraged and not cost effective. The sensitivity, specificity, and impact upon the care of number of commercially available antibody tests are uncertain. Without clinical clues to etiology, selective use of tests are based on the neuropathic syndrome is preferred. So what's the role of a skin and nerve biopsy? The sural nerve biopsy yield diagnosis in about 27% of the cases, provides useful information in about 37%. When you have vasculitis, you usually do a superficial peroneal or a superficial radial. You need an involved nerve to be biopsied because it's important to look at a conduction and do the involved nerve biopsy. Look for role for triple biopsy, which muscle, skin, and nerve increases the diagnostic curve. You do an epidermal nerve fiber density with PGP 9.5. This is an early vasculitic disease where you actually see perivascular inflammation with the intact vessel wall. Next one is a fibrinoid necrosis, where you actually see a hyaline staining in the inner regions, and there is significant, this is actually a necrotizing vasculitis where you really need to be aggressive in management, and you need to use drugs like cytotoxic drugs like cyclophosphamide. So it's a fibrinoid necrosis at the hallmark of necrotizing neuropathy, and you need to be very aggressive with the treatment. You sometimes see skin biopsies showing perivascular inflammation. Yeah, there are pitfalls in the evaluation of neuropathy. Sometimes you see lumbosacral radiculopathy masquerading like a neuropathy, distal myopathies, ALS coming with foot drops. You may have a demyelinating disease looking like a sensory neuropathy with a neuralgia parasitica. So it's important to look at the pitfalls. I'll show you one patient who is a doctor who presented to us with a 3 months history of neuralgia parasitica on the right side. Her conductions were all normal, but needling showed the lumbosacral plexus to be affected. And the MRI showed an L5 as, MRI is a very sensitive tool. It shows an L5S1 disc, but this was not relevant. On examination, she actually had a peduncular fibroid, and when she lies on the right side, the peduncular fibroid goes and presses on the plexus, and she was getting a neuralgia parasitica lesion. And she had surgery and she had complete improvement. So when somebody comes to you with neuralgia parasitica, it's important to, you may not be able to do a lateral cutaneous nerve of tie conductions, but you need to needle the vastus medialis lateralis and investigate appropriately so that you don't miss a sinister lesion. Next one is an elderly man who came to us with a 10-day history of gluteal pain, tingling sensation of the dorsum of the foot and weakness of the right foot, had a procedure done 2 weeks ago. And the conduction showed involvement of the sural snaps, the superficial snaps were gone, significant denervation of the lumbosacral myotomes of the tibialis anterior, tibialis posterior, and the biceps femoris. And patient had actually a piriformis syndrome and a hematoma in the piriformis and a pseudoaneurysm. We had to do an angiogram and we had to evacuate the hematoma. Basically, it's a procedure-related sciatic hematoma. So it's important to target your investigations based on the nerve conduction studies. So this shows the large hematoma, and this was evacuated and the patient did well. Sometimes the diagnosis of neuropathy is right, but the cause is falsely attributed. You might have a painless or a painful subacute weakness on the background of a chronic distal sensory, and the conductions may show features of a plexopathy. This is a patient with a lumbosacral plexopathy, which is a vasculitic neuropathy in a diabetic with severe painful pre-treatment showing enhancement and post-treatment showing improvement. And if you do a biopsy on these patients, you see sectorial loss, and it's a microvasculitis, is eminently treatable, described by Peter Dick and colleagues. Now, false negative diagnosis occurs in the setting of a mild sensory neuropathy or small fiber neuropathy. The examination findings and yield of conventional conductions are low, so you need an epidermal nerve fiber density using special stains. This is a normal showing the epidermal fiber density. This is showing breakage of the thing. So this is usually actually came into vogue when they were looking at HIV neuropathies. So as I told you before about the spatial patterns, you may have a focal neuropathy, mononeuropathy like a carpal tunnel syndrome, or a ulnar neuropathy at the elbow, or a monoradiculopathy like a cervical radiculopathy, a lumbosacral radiculopathy. Or you may have a multifocal disease like a multifocal motor neuropathy or a polyradiculopathy, plexopathies or motor neuropathies or motor neuropathies, or diffuse like polyneuropathy or DRG. What are the differential diagnoses of acute neuropathies? Sensory motor axonal is usually AMZON, acute motor sensory axonal variant of GBS, a vasculitis, alcoholic neuropathies, nutrition and toxic. Predominantly motor axonal could be acute motor axonal neuropathic variant of GBS, porphyric neuropathies, Dapson, Winchester, and not to forget critical illness neuropathy, because you see this very common in the ICU settings. So when olden days, we used to have bellows ventilation. With advance in medicine and technology, survival increased and we put patients on sedation, but people survived, but their morbidity increased. So Bolton described in 1984, 5-week patients which were acute severe axonal neuropathy with no demyelinating features, normal nerve conduction velocities. They had sepsis and MODS and poor nutrition, and he called it a critical illness polyneuropathy. So in our ICU, we did a study and we found 90% of our ICU patients had electrophysiological abnormality. About normal group were only 10%. 33% of patients actually have CINs and pure motor, critical illness motor syndrome. So it's very important when you're called in the ICU, patient on ventilator, failure to wean, get a conduction done and look for critical illness neuropathy and look whether there is evidence of MODS or systemic inflammatory response syndrome, is a sepsis and all that, which are precursors for critical illness neuropathy. If you look at subacute neuropathies, sensory motor axonal, B12, B1 deficiency, gastric surgery, Celix Prue, Whipples, alcohol, arsenic or thallium, organophosphorus toxicity, diabetes, hypothyroidism. This is going to be discussed later, Lyme's disease, HTLV1, paraneoplastic. Predominantly motor axonal could be subacute neuronopathy, CMTX, CMT2, lead poisoning, Winchester, hypoglycemia. Sensory alone axonal could be idiopathic acute sensory neuropathy in the acute setting, paraneoplastic, acute pyridoxine toxicity, cisplatin, spacitaxel, Miller-Fisher variant. Subacute chronic could be paraneoplastic or paraprotein, mitochondrial cytopathy, thalidomide. It's a long list. It's difficult to go through all of them. Demyelinating neuropathies, as you know, the prototype is AIDP, HIV-associated AIDP. Diphtheritic neuropathies are not too uncommon. Motor more than sensory, CMT1A and B, CMTX, CMT4, MLD. Demyelinating neuropathy subacute could be a CIDP or a POEM syndrome or MGUS, hypothyroidism, amiodarone, chloroquine, GVHD organ rejection. Sensory motor indeterminate could be diabetes mellitus, end-stage renal disease, CIDP or CMT1B or CMTX. Differential diagnosis of sensory motor axonal acute vasculitis, Lyme's neuropathy, Lyme's disease, where you can have a facial and a severe axonal polyradiculopathy. Subacute, again, vasculitic syndromes, cryoglobulinemia, diabetes, sarcoid. Acute demyelinating, as I said before, AIDP. Subacute CIDP could be MATSOM, HNPP, or leprosy. Demyelinating motor alone, multifocal motor neuropathies. Predominantly small fiber neuropathies are common in acute neuropathies in diabetes. Idiopathic small fiber neuropathy or acute pan dysautonomia could be like a GBS variant causing only pan dysautonomia. We have reported one case in a post-MUMS which recovered completely with IVIG. Chronic could be diabetes, marked hypertriglyceridemia, Sjogren amyloidosis, Fabry's and Tangiers. There are so many clues to neuropathy. You need to look for skin appendages on renal. It would be hyperpigmentation or hypopigmentation, vitiligo, ichthyosis, or photosensitivity in vasculitis, angiokeratomas or dupuytren's, Mees lines in toxins, hair loss, glossitis, chelosis, macroglossia in amyloid neuropathies, erythema migrans in Lyme's disease, erythema nodosum. So these are a few of the markers. So this is very important, this slide, to show you have to look at the patient in detail, look for sclera, uvea, sinuses, look for the GI system, look for the renal system, look for the peripheral nerve, look for the lungs, look for the heart, look for the bones and joints and the skin. So it's you have to really have an internal eye when you look at these patients and not the brain. Acute abdomen, look for porphyrias and lead poisoning. Chronic diarrhea, malabsorption syndrome, Whipple's and celiac disease. Look for Raynaud's disease, arthritis and asthma. Lymphoreticular is POEMS and Waldenstrom's macroglobulinemia, lymphoma, HIV. Orange-Johnson's and Tangiers, cataracts and corneas, retinal vasculitis or RP, papilledema. Hearing problem can be seen in Refsum's, Cockayne syndrome, or mitochondrial cytopathies. When you have a sensory motor axonal polyneuropathy, acute, occasionally you need an LP, a 24-hour urine arsenic, thallium. You look at porphyrins, urinary and fecal porphyrins. If you have thiamine deficiency, you look at cell transcutulase. Lyme's disease, if you have a facial weakness and also a severe polyradicular neuropathy. Predominantly motor axonal, you look for lumbar puncture, urine for toxins. Subacute and chronic, you look for serum and immune electrophoresis or immunofixation, GM1 gangliosides, genetic testing. If you have sensory alone, you look for ANA, anti-Ro and anti-LA, screen for occult malignancies, look for onconeural antibodies, HIV neuropathies, screening. Demyelinating neuropathy, you leave it at lumbar puncture, HIV serology and Lyme serology. Subacute neuropathies, lumbar puncture. Again, you look at FBS, HB, and AC, serum immunofluorescence. Occasionally, CMT1B, which will be discussed later. Sensory motor with indeterminate, you can look for lumbar puncture, FBS, and HB1AC. If you have uniform neuropathies, you look for inherited neuropathies. If you have a small fiber neuropathy, you look the inventory questionnaire, look for peripheral pain, paresthesias, allodynia, diminished temperature, pain sensations. Look for Zika symptoms, accommodation disturbance, hyper or hypohidrosis, micturition disturbance, erectile dysfunction, decreased lubrication, gastroparesis, diarrhea, constipation, facial flushing, and osteostatic symptoms and palpitations. You need to screen these patients for diabetes, look for impaired glucose tolerance and hypothyroid, look for heart neuropathies and HIV, metronidazole, bortezomib. Immune-mediated, look for celiac disease and sarcoid and Sjogren. Familial burning feet. I won't go through this. This is going to be discussed later. This is a lady who came to us post-pregnancy with a SEP9 gene mutation with hereditary neurologic hemiatrophy, showing thickening of the plexus. This is a patient with a sensory ataxic neuropathy with dysarthria and ophthalmoparesis due to Paul G mutation, will be discussed later. So I won't go into inherited neuropathy, it's going to be discussed later. Look for deformities in Charcot-Marie tooth, claw tooth, toes, pes cavus, hindfoot varus deformities, pes cavus. This is very important. Autoimmune ganglionopathy showing marked anhidrosis, where these are actually profoundly treatable. And you can see these can be treated with IVIG and patient can markedly improve. This is from the Mayo Clinic group. This is a 48-year-old man, a vignette showing a patient with chronic diarrhea, satiety, weight loss with paresthesias of 8 months duration. Came to us with acute delirium and tachycardia. He had neuromyotonia, and on detailed evaluation was found to have a thymoma and had Morvan syndrome. So it's very important to investigate this patient. Again, not to forget paraneoplastic syndrome, subacute sensory neuropathy associated with small cell carcinoma of the lung with anti-HU antibodies. There's loss of neurons in the thoracic sympathetic ganglia, DRG. This could be associated with malignancies with anti-HU, anti-CV2, and CRMP. 30% of the anti-HU antibody patients have autonomic dysfunction. And anticoagulonic acid receptor antibody patients, 20% of them have autonomic neuropathy. This is a series from us with 44 patients with paraneoplastic syndrome. Mean age is 54. 2% had acute presentation, subacute was about 35%, and chronic 63%. 91% had paraneoplastic syndromes, and 9% had an underlying tumor. If you see, about 14 of the 44% had neuropathy, polyneuritis cranialis in 1, cardiac 1, and 1. So it's important so these are the various tumors like lymphoma, breast, ovary, prostate, renal cell carcinoma. It's important now with PET-CT, we can pick many of these patients. These are the onconeural antibodies, anti-HU, anti-U, anti-RE, anti-HU, MA2, and U. Sjögren is a very important syndrome to be detected because when you have a patient come to you with sensory ataxic painful neuropathy, dryness of the mouth, you really need to investigate this patient with anti-Rho and anti-La, and you may need to do a lip biopsy looking for features of lymphocytic infiltration because it's eminently treatable. HIV neuropathies is rapidly increasing to epidemic population, and the prevalence is as high as 55%. Antiretroviral toxic neuropathies are associated with stavudine, salcitabine, and diadenosine. Early HIV disease can have seroconversion related neuropathy, GBS, or moderately advanced can CIDP, or you can have a diffuse infiltrating lymphocyte syndrome or a syphilitic or a CMV radiculopathy. Due to paucity of time, I wouldn't be able to describe all of them. Advanced HIV can be distal sensory symmetric neuropathy or an HIV-related or CMV-related radiculopathy. Medication-related neuropathies, as I said before, are diadenosine, stavudine, and salcitabine. INH and ethambutol can also cause neuropathies. We had a study done, and we actually found that we have about 13 patients actually had, 7 of them had motosensory axonal neuropathy, 2 had sensory neuropathy, 2 had polyradicular neuropathies, and mononeuritis multiplex. So when you have a neuropathy, you need to have an algorithm. What is the spatial distribution? Is it a mononeuropathy? Is it a symmetric neuropathy? What fibers are involved? Is it a small fiber, large fiber? What is the temporal profile? Is it acute, subacute, or chronic? Pathology, is it axonal versus demyelinating? Is the disorder familial? What are the medical conditions and neurotoxins? If there is a specific etiology suggested, you do confirmatory test, lab, and biopsy. If it's no, you need to do screening tests based on the physiological studies. Usually an etiology is established in about 80%, and 20% still remain cryptogenic. So when you have a patient coming to you with, you actually do a nerve conduction study. Somebody comes to you with a carpal tunnel syndrome, you do a nerve conduction study, you confirm the carpal tunnel syndrome, and sometimes you find patient has a widespread neuropathy on top. Or if a patient comes to you with a peripheral neuropathy, you look at, is it an axonal or a demyelinating disease? If it's axonal, you look, is it an acute, subacute, or chronic? If it's demyelinating, you say, is it an uniform slowing like an inherited neuropathy, non-uniform neuropathy like a GBS or CIDP? Or multifocal neuropathies where you look for vasculitis, diabetes, sarcoid, and leprosy, or you look for conduction blocks in the form of multifocal neuropathies. So summarizing, neuropathies are commonly encountered in the primary care settings. You really need to screen in systemic disorders. Highest yield is for DM, B12, and serum protein electrophoresis and inherited tests. You really need a good internist eye and a focused electrodiagnostic test, and judicial lab test needs to be done. Thank you very much. Thank you.
Thank you, Professor Matthew Alexander. It's a very comprehensive and nice talk for approach to the peripheral neuropathy. May I invite inflammatory neuropathies, Professor Mohan Madhusudan. Professor Madhusudan, please.
Yeah.
He is Senior Consultant Neurologist, PRS Hospital, Trivandrum, Professor Emeritus, Medical College, Trivandrum, Professor and Head Neurology, Pushpanagri Institute of Medical Sciences, Adjunct Professor of Neurology, Manipal University, Manipal. He is already FIN, and his major achievements are lots. May I request Dr. Madhusudan to please start your delivery.
Thank you, sir. Am I audible to you?
Yeah.
Yeah. So at the outset, I would like to thank the organizers, IAN team, and especially Professor Nirmal Surya for inviting me to partake in this conference. So I will start my share my screen. Is my screen seen to you all?
Yes.
Yeah. So this part of my talk has been made simple by the talk by Dr. Matthew. He has covered some of my points which he wanted to say. As he said, peripheral neuropathy affects about 2.4 to 7% of the population. The inflammatory neuropathies constitute about 20 to 30%, and the immune-mediated neuropathies constitute about 20%. In my talk today, I'll be confining myself only to the immune-mediated neuropathies. As you know, as Matthew has already told you, the site of lesion in any neuropathy can be in the ganglion, in the sensory neuronopathy. In our context, it is sensory ganglion, or maybe roots, maybe in the plexus, it may be in the nerves, or it may be a combination of roots plus nerves. Now, the classification of immune neuropathies can be classified in 3 ways. This also Matthew has covered based on the duration, progression, based on the type of dysfunction, based on the electrophysiological dysfunction. Based on the progression, it may be acute, by which we mean less than 4 weeks, subacute 4 to 8 weeks, and chronic more than 8 weeks. Based on the physiological dysfunction, it may be pure motor, pure sensory, pure autonomic, and often a mixed pattern is seen. Based on electrophysiologically, it may be demyelinating, it may be axonal, and a new entity which I am going to talk today is the axonal conduction block, which is it can either turn into demyelinating or axonal variety, and some of them are totally reversible. Now let me classify the immune neuropathies, which can be grossly classified acute and chronic. Now I first deal with acute sensory motor presentation, then by which we mean the sensory fibers and the motor fibers are affected acutely. It can be classified into 2 broad categories, symmetric and asymmetrical involvement. Symmetric can be one type, there is a commonest type, the demyelinating. Second is the axonal one. The demyelinating one, which is predominantly proximal, is the classical AADP, the ordinary garden variety of GBS syndrome. The axonal variety, which is predominantly distal, is AMSAN. This is just like AMAN variety, where the pure motor is affected. Here, motor and sensory is affected, but demyelinating type and an axonal type presenting in a distal fashion, affecting both motor and sensory. Now come to the asymmetric pattern involvement. The demyelinating one is the MADSOM variety, and the axonal one is the mononucleus multiplex. Here, remember that this MADSOM variety, that is multifocal demyelinating sensory and motor neuropathy, can present acutely and can present chronically. So this classification will come under chronic variety as well. And let's talk about something about the symmetrical neuropathies first. First about the AADP. I will not spend time on that. All of you know about it. Just run through that in the interest of time. Both motor and sensory is affected, predominantly motor. They can have global reflexia. They can associate canine neuropathies, respiratory and autonomic affection. The diagnosis is electrodiagnosis and CSF study. The other one is the axonal variety is predominantly affecting distally at the MSAN. It is similar to AMAN but associated sensory, and a length dependent affection, meaning there by the distal part is affected, as you can see in the diagram. And coming to the asymmetrical variety is the maximum and the mononucleus multiplex. And it can sometimes be confined only to one limb, where the acute brachial plexopathy can be a manifestation of asymmetrical demyelinating neuropathy. Asymmetrical axon is mononucleus multiplex, which can present as a demyelinating one. But remember, the more common one is the vasculitis, about which Matthew was referring to, which can present as multiple nerve involvement. Suppose if the presentation is acute motor only without any sensory, again you can divide it in two categories. One is symmetrical and asymmetrical. Symmetrical demyelinating one, predominantly proximal, is acute motor AADP. Here AADP can present in various ways. That is why classic put it under the pure motor variety. The pure sensory variety is also putting it under, because the presentation can be varied. The axonal variety, predominantly distal, is the common AMAN variety. The AMAN and the AADP are the two common presentations of GBS. Now, the asymmetrical variety demyelinating is acute motor AADP. Then you may think, why I have put acute motor AADP under both symmetrical and asymmetrical? If you look carefully, most of the GBS syndrome, acute and AADP, they have some asymmetry with them. It's not uniformly symmetrical. So they kind of asymmetry is not against an AADP. So that is why I put it under that. The axonal variety is the mononucleus multiplex and focal syndromes like plexopathies. Now coming to the motor neuropathies, pure motor, demyelinating AADP. When the picture is only purely motor, you have to consider other different diagnoses which Matthew has mentioned. I will come to that a little later. The axonal type is the AMAN, that is predominantly distal. So AMAN is symmetrical. It's progression over 4 weeks. Pure motor dysfunction without sensory can have distal reflexia. But remember that some of these persons with AMAN variety can have a brisk reflex as well. Not only with the initial period, maybe throughout the course, the reflex can remain brisk. Unlike AADP, autonomic dysfunction is less common in this AMAN variety. Now, this is what I am referring to. When you get a pure motor syndrome, always try to roll out other conditions which we can mimic in pure motor syndromes. For example, those affecting the neuromuscular junction or the muscles can come in the different diagnoses, like myasthenia, acute myasthenia, botulism, inflammatory myopathies, periodic paralysis, polymyelitis, hypermagnesemia, porphyria. Tendon organic phosphorus should be kept in mind before considering the possibility of an immune-mediated neuropathy when the only motor system is affected. The acute motor variety, asymmetrical one, again demyelinating acute motor AADP as well as mononucleus multiplex. As told before, AADP can be purely motor alone, that you have to keep, can present asymmetrically also, is already told. Now coming to the acute sensory presentation, it can be symmetric, demyelinating, and you find pure sensory AADP. And if it's asymmetrical axonal with absent snap, it's acute ganglion neuronopathy. In ganglion neuronopathy can present acutely, as already Matthew has mentioned, post-infective and toxic. Sometimes it can be chronic, as in paraneoplastic syndromes. So this ganglion neuropathy will also come into the chronic variety, which I'm going to talk to you later on. So here is acute presentation of sensory neuropathy as an immune-mediated mechanism, that is pure sensory AADP and acute ganglion neuronopathy. But remember, one is demyelinating, the other is axonal. The axonal variety will produce absent snap, whereas demyelination most of the time may not produce if there is a proximal demyelinating lesion. The other is acute autonomic neuropathy. This again Dr. Matthew has alluded to. It may be pan-dysautonomy, is more common than isolated cholinergic or sympathetic involvement. This is 70%, the other is only 29%. And the symptomatology has been covered. Cholinergic dysfunction, sympathetic is a sympathetic dysfunction. Now let's talk about a little bit about the autonomic neuropathy. Is an uncommon syndrome. The deficits evolved like over 1 to 3 weeks, just like an AADP. The symptomatology may be an autonomic dysfunction. The clue to diagnose an immune-mediated autonomic neuropathy is the CSF is elevated and they respond to immunosuppressive treatment. When you say GBS, any acute presentation of all these variety, whether it is pure motor sensory, or pure sensory, or autonomic, all can be classified come under the GBS pattern. But you should also remember that GBS can have some atypical presentations. Need not AADP did not have the classical proximal more, distal more like that. The weakness in sensory signs can be asymmetrical, predominantly proximal or distal. It can start in the legs, can start in the arm, or simultaneously in all the 4 limbs. Severe pain and diffuse pain or isolated cranial dysfunction can precede the onset of their weakness. The pain may sometimes confuse you with lumbosacral radiculopathy due to disc prolapse. Young children can present with atypical features such as poorly localized pain, refusal to bear weight, irritability, meningism, and unsteady gait. So again, you should be very cautious not to miss an AADP in children. There are very many GBS variants. The presentation is not uniform. The classical one is given on the left, that is sensory motor, or it may be pure motor as you can see here, or it may be paraplegic variety where the findings are confined to the lower limbs, or the finding weakness may be confined to the pharyngeal, cervical, and brachial musculature, so called the PCB variant, or it may be only confined to the facial muscles with sensory findings in the distal part, or the other way is a pure sensory variant, or the Miller-Fisher syndrome where they can associate it ataxia with ophthalmoplegia, and the Bickerstaff's variant, which is an added on to that, there is a CNS demyelination producing the altered sensorium and pyramidal signs. Having said this much about the acute neuropathies, I will go to the chronic variety. Again, we can divide them into chronic sensory motor, pure sensory. Let us see the chronic sensory motor. May be again symmetric or asymmetric. Symmetric can be demyelinating, predominantly proximal, just like AADP, but here it is a chronic one we call the chronic AADP. So it's a chronic type of an AADP, it's a chronic one. Now the symmetrical axon one, which is predominantly distal, is CASAP, that is chronic inflammatory axonal polyneuropathy, which is here it is both motor and sensory. Sometimes you may find that the peripheral conduction may be normal. You get a normal CMAP, normal SNAP. The only abnormality may be a proximal problem. The only F and H may be abnormal. There the problem is the cytoglycation, the radicals, the roots. So we call it as a chronic inflammatory sensory motor polyradiculopathy. The symmetric one may be demyelinating, may be MATSM, that's CADP variant, whereas the name suggests it is multifocal, not symmetrical. And axonal variety is monoitis multiplex. As told before, it can come under monoitis multiplex, and MATSM can present acutely as well as chronically. So yeah, that's why I put it here in this classification. Now coming to the symmetrical chronic sensory motor inflammatory neuropathies. The typical one is a CADP, predominantly motor, leg onset, proximal weakness more than the distal, progressing for more than 2 months, maybe relapsing, diffuse areflexia. They can have distal paresthesia due to large fiber sensory loss. Again, 20% of the cases of CADP are atypical. They are called variants. It may be variants may be in the distribution of the nerve involvement, or variants may be in the functional and temporal aspects. The distribution may be multifocal, that CADP we call MATSM variety, or they may be confined only to the distal part, the distal CADP, others called the DATS variant, or paraplegic variant confined only to the lower limb, or a focal CADP, for example, in the case of a chronic variety of a brachial plexopathy. Even isolated cranial neuropathy can also sometimes come under this category. The functional variant can be pure motor CADP, percentile CADP, and ataxic type, which is usually seen in the Cano-MAD type, and the CASP, that is chronic inflammatory sensory polyradiculopathy, about which I'll be talking a little later. Suppose if you find the progress is more than 4 weeks but less than 8 weeks, There is no man's land. It's called subacute inflammatory neuropathy. It can either turn into reverse back to normal or can go into CADP type. 80% of them do not relapse within 2 years if they is subacute one. 17% evolve into relapsing CADP. Always keep some red flags in diagnosing CADP. That's if you get absence of weakness, particularly proximally in the neuropathy, don't jump into the conclusion to diagnose CADP. Beware of the atypical CAD presentations, asymmetrical leg presentations. The patient has no gait disability or sensory ataxia. Again, be cautious. Pain and fatigue as predominant symptom, sphincter issues and autonomic symptoms. CADP diagnosed mainly on NCS and spinal fluid protein, and only leg showing NCS and refractory to first-line therapy. Always keep other differential diagnosis with Matthew as mentioned as in your differential diagnosis. Now coming to this entity, that is CADP I mentioned. Now go to the CAAP, that is an axonal variety where it is symmetrical, progressing, length dependent, distal more than the proximal. Here sometimes vasculitis also you have to keep in mind. Here because sometimes vasculitis may not always present like a mononeuritis multiplex pattern, which is a common one. They can also sometimes present with a distal predominating neuropathy, mimicking a peripheral neuropathy. Then this is the affection. If the affection is in the radical, this is called, when both motor and sensory affected, we call it chronic inflammatory sensory motor polyradiculopathy. Is usually asymmetrical, non-length dependent. The snaps are normal because the lesions happen to be distal to the sensory ganglion. Motor conduction can be normal because if the demyelination is confined to the proximal part, the peripheral conduction will be normal, but only can be picked up by F5 and HV abnormality and by SSCP. Now there is just an asymmetrical variety which already I had mentioned earlier, that will not go to that. There is a Madsen variety for focal CADP. They are similar to mononeuritis multiplex, but here the pathology is demyelinating. In classical mononeuritis multiplex, it is axonal. Usually it starts in the upper limb. It is painless as opposed to the classical vasculitis producing mononeuritis multiplex, which is painful. Focal CADP is site restricted, confine only one site, for example, neuralgic hemiatrophy. Then coming to the axonal variety, that is classical mononeuritis multiplex, already told you, it's usually painful. Now coming to the third category of a chronic pure sensory involvement, again maybe symmetrical, asymmetrical. A symmetrical one which is demyelinating is affecting the distal part of the nerves is actually the DADS variety. The distal variety of demyelinating sensory neuropathy. Distal acquired sensory neuropathy. The other is asymmetrical one which may be demyelinating, which usually affect the proximal roots. That is called sensory inflammatory sensory polyradiculopathy. Or it may be axonal where the ganglions are affected. You can axonal degeneration, you get a chronic sensory neuropathy like that. Now let's come to the symmetrical demyelinating neuropathy presenting as a chronic sensory one. It's called the DADS. It can have minimal, later on they can have minimal effect on the motor nerves. Insidious, slowly progressive over years. They present with distal sensory loss, ataxia, and upper limb tremor. NCB show distal demyelinating signs, and some of them are associated with paraproteinemia. This is called, when is DADS I is called idiopathic, M being associated with paraproteinemia. Only the I variety, the idiopathic variety, comes under the classification of CADP. The paraproteinemia DADS is essentially a different one. The treatment is also different, and 75% of them due to an associated condition called anti-MAG neuropathy. Now coming to the chronic asymmetric neuropathy demyelinating sensory polyradiculopathy. Here the site of affection is in the roots. They present sensory loss and gait ataxia. Sensory conduction is normal since affection is distal to the ganglion. The only abnormality may be in the SSCP and sometimes H reflex. The diagnosis by elevated CSF protein and MRI showing thickened nerve roots. The other is the ganglion neuronopathy, the site of sensory ganglion. Same presentation as that of CASP. Only thing is that here the NCB shows absent snaps because it is affecting the ganglion cell causing axonal degeneration. Then coming to the pure motor variety, chronic one, maybe again symmetrical, asymmetrical. If it is demyelinating, it's a pure motor CADP. As told already before, CADP can be variants by pure motor, pure sensory. Yes, pure motor, you come under this category. If it is axonal, you get CAAP variant. There's nothing but Naman-like thing, but present in a chronic fashion. The symmetrical demyelinating can be multifocal motor neuropathy with conduction block. If it is axonal, it is multifocal acquired motor axonopathy. Only difference between the last two is one is demyelinating, the other is axonal variant. So coming to the CAAP, that is chronic inflammatory axonal polyneuropathy. This condition has to be differentiated from a chronic idiopathic axonal neuropathy, which is much more common. But the latter variety is not immune responsive and not due to an immune-mediated one. Unlike the present one, which we have included here, is mediated, an immune mechanism is operating, and they respond to immunosuppressant treatments. And the evidence is axonopathy, and the clue is that elevated CSF protein and the nerve biopsy showing abnormality approximately if they can do it. Second is the asymmetrical demyelinating variety, that is multifocal motor neuropathy with conduction block. As the name suggests, pure motor, no sensory, slowly, stepwise progressive, predominantly distal involvement, usually upper limbs are affected first in the radial nerve distribution. Wasting and fasciculation is present. In most patients, tendon reflexes are reduced in a patchy way or diffusely, but may be normal or even brisk in 20 to 30% instances. If you find a brisk reflex situation, one always be confused with the possibility of a motor neuron disease. Electrophysiology shows demyelination with conduction block, but then sometimes conduction block may not be there, still the patient may be responding to immunosuppressive treatment. In 50 to 60%, you may find anti-GM1 antibodies of IgM category. Second is the axonal variety, just like multifocal motor with the conduction block. Only thing is that here there is no conduction block and the electrophysiology is axonal. Now, having said this much about the classification, but remember that all these names have been given for these conditions. But only thing is that, as Matthew said, it all depends upon which part is affected. So immune-mediated neuropathy can affect roots, can affect the plexus, can affect the nerves. And the symptomatology depends upon whether one is affected, asymmetrically affected, symmetrically affected, whether motor is affected, sensory is affected, mixed is affected. Forget about the terminology. It all depends upon which part is affected. That determines the clinical symptomatology. So immune-mediated neuropathy can affect in all these ways. Now, I'll spend some time on this condition, this one, electrophysiology. This, all of you know about the two main things, axonal degeneration, where the bundle of attacks the axon with the distal degeneration. Here, the electrodiagnostic abnormality is absent irrespective of the site of lesion. Whether it's proximal or distal or in the cell body, you want the same electrophysiological picture. In segmental demyelination, as the name suggests, the axon gets denuded of its myelin sheath. Here, the electrophysiological abnormality depends upon the site of demyelination. For example, if you find a demyelination occurring proximal to your proximal site of stimulation, you get a normal CMAP. Whereas only between the proximal distal stimulation, you get a classical conduction block. If it's distal to that, you get a decreased CMAP with proximal distal stimulation. That means it may mimic an axonal degeneration. So demyelinating pattern, the abnormality vary depending upon where the demyelination is present. And if there is in segmental demyelination, you get associated finding like the widened CMAP and the regular CMAP. Now, I'll spend 2-3 minutes for this NDT because this has come as a big way in the diagnosis of so-called AADP, electrophysiological diagnosis of AADPs. AADP amine variety. This is a new electrodiagnostic abnormality due to the effects of the node. Here there is a conduction block, but there is no dispersed potential. And that you may find mild slowing, but not a severe slowing. Here this is abnormality occurring in the node, but the subsequent, the myelin sheath are not affected. So what happens if you find a nodopathy occurring in this region between the proximal distal stimulation? what you're going to get is the distal amplitude is low. You get a classical conduction block mimicking empty myelination. If it happens to be distal to that, you get decrease in amplitude, again without any dispersion, only the block amplitude comes down, again it mimics axonal degeneration. Now, if you get what are the consequences of nodal affection, it can cause a reversible conduction block or it can cause axonal degeneration. What is reversible conduction block? Imagine the lesion is here, you get a classical conduction block. But suppose there is a rapid recovery of the nodal pathology, the receptors have rejuvenated, the antibody attack has subsided. That becomes on follow-up, that recovers. The conduction block improves, just like any other demyelinating lesion, and got a rapid recovery also. The other thing, which if it is happened to be distally, the electrophysiologically mimics axonal degeneration, but on follow-up, that also improves. So here, this particular variety of MI may recover very fast, but actual pathology is not in the axonal degeneration, but a distal nodal block due to the nodopathy. On the other hand, a nodal affection can subsequently lead on to axonal degeneration. The axon get degenerated if the immune attack on the node is very severe, as you can see here. So here's what happened. It occurs here. You get a conduction block, but on follow-up, that nodopathy does not recover, resulting in subsequent axonal degeneration. So what will happen? The patient will have persistent low CMAP amplitude and the persistent axonal degeneration. So this is the one which was originally we thought the MRMAN is very poor prognosis, and because some of them go into axonal degeneration. So, but remember that unless you do a repeat conduction, one may be confused as to whether the initial track is a reversible one or a one which is going to have a persistent neurolytic deficit. So reversible conduction if MRMAN may be mistaken if conduction block in AADP if only one NCS is done. Now I'll briefly touch upon the pathophysiology of immune neuropathies. As told before, it is the antibody-mediated attack on the certain antigens in the nerve. So to understand this, we must know a little about the antigenic properties of the node and the paranode. The myelinated fibers are organized into distinct domains like node, paranode, distal paranode, and internode. The nodal sodium channels are anchored to the spectrum of the axonal cytoskeleton by the anchorin G, and this is anchored to the gliomidin of the strand cell by a neurophase in 186. So this molecule you have to keep in mind, the antigen, the neurophase in 186. At the paranode, Casper, that is contact-associated protein, and contactin are tightly connected to the neurophase in 155, as you can see here. So this complex forms septate-like junctions which separate the nodal sodium channel from the juxtanodal potassium channels. The juxtanodal potassium channel is also anchored by certain glycoprotein like Casper2 and TAG1. Now, the presence of autoantibodies, activation of the complement, and reactive T cells and macrophages results in inflammation, leading on to myelin loss, axonal degeneration, disruption of the nodes of Ranvier. How exactly the autoimmunity has been occurring, we do not know, but that is triggering factors, as you all know, Campylobacter jejuni is the triggering factor for the amine variant. However, in most cases, the exact mechanism remains unknown. Now, let us see what are the antigenic targets. We do not know the antigenic targets in all immune neuropathies. For example, in classical AADP and CAD, we do not know which antigen the antibody is attacking. But the main player in the other neuropathies are the anti-ganglioside antibodies and the antigens which I already mentioned before. Now, what are gangliosides? They are important compounds peripheral now. They are glycolipids consisting of a lipid ceramide component, a sugar moiety, and sialic acid. I think I will not spend on that. Depending upon the number of sialic acid residues, they are called GM, M means mono, D di, T means tri, and Q means quadra. Depending upon sialic, they have been classified into GM1, GD, GT, and GQ. And the B stands for the designate the sialyl group attached to the internal galactose. These anti-ganglioside antibodies are also neuropathies. IgG anti-GM1, anti-GD1A antibodies are associated with AMAN and AMSAN. Anti-GQ1B antibody is associated with the Fisher syndrome, Miller-Fisher syndrome, ataxic GBS, Bicester brain stem encephalitis, the pharyngeocervical brachial weakness type of AADP. They are lumped together as anti-GQ1B syndrome. IgG anti-GQ1B antibody and IgG anti-JD1B antibody can be associated with chronic ataxia neuropathy. Whereas IgM variety of GM1 is responsible for the multifocal neuropathy with conduction block. If you go to the pathogenesis of CADP, the antibodies directly attack the myelin or the internode, so it can be called as internodopathies, but the antigenic target is largely unknown. Now, apart from the gangliosides, there are other antigenic targets at the node, in the node or paranodal region, which can cause either AADP presentation or a CADP presentation. They are already mentioned here. I think the clinical presentation depends upon the type of antibody and the antigenic targets attacked with antibody. The type of antibody depends upon the viral and bacterial antigen mimicking the target antigen, so-called molecular mimicry. So, for example, in this case, the antibody is attacking the NF186, the neurophysin 186. The presentation is different. They present subacute onset severe ataxia with the tremor, and they are responsive to IV agent rituximab. If it is attacking against NF151, they are occurring in younger age group, tremor predominant, distal weakness, but poor IVIG response, but rituximab may be effective. If it is attacking against the Casper contactin complex, they got predominant pain with nerve root enhancement, but poor response to IVIG, and rituximab may be effective. Whereas here, in this variety of contactin antibodies, the responsible for that, this person, older individual with aggressive onset, and they again got poor IVIG response, but rituximab can be effective. So here, if your patient is not responding to your IVIG or plasmapheresis, you have to consider that whether are we dealing with this kind of paranodopathies causing AADP and CADP, and think about alternate line of management. So what are the clues to suspect node and paranodopathies? Aggressive, young age and early cranial involvement, nephrotic syndrome, think it may be anti-NF151, anti-contacting. Poor IVG response, anti-contacting, anti-MAC, poems, and amyloidosis. You got central demyelination, think of this combined central and peripheral demyelination, think of anti-NF151. Tremor-dominant ataxia out of proportion, anti-NF151, MAG, and canamide. Intense neuropathic pain, think of anti-Casper antibody. Now, what are the clinical relevance of these antibodies? In GBS, antibodies against 155, 186 Casper may be derived only very rarely. So there is no point in checking these antibodies. Instead, if you find these antibodies in a GBS patient, it may be a marker for the development of an acute onset of CADP. That means that patient is going to develop a CADP later on. Although some of these patients are unlikely to respond to IVIG, they could still respond to steroids and an immunosuppressive drugs and plasma exchange. There is a role for IVMP, IV methylprednisolone in such situation where we are not able to check the antibodies. About 50% of these patients show good response to rituximab. So I think I have exceeded my time by 1 minute, 2-3 minutes. So I will stop at the last 2 slides. In treatment, all of you know about the treatment is just like any other immunotherapy. In GBS, IVIG and plasma exchange are proven to be effective, whereas corticosteroids are not. CADP, corticosteroids, IVIG, plasma exchange are equally effective. Multifocal motor neuropathy, only IVIG is proven to be effective. Rituximab in some cases, whereas steroids are not effective. Anti-MAC neuropathy is very difficult. Rituximab is the treatment of choice. There is a new way of administering IVIG, subcutaneous, because to avoid the cost and the cumbersome method of giving IV infusion. This is another method. I will again not go into the detail. For the treatment of multifocal motor neuropathy, IVIG is the first line treatment. They do not respond to steroids or plasma exchange, even may make it worse. Some studies have shown beneficial effect with cyclophosphamide. So I think I'll stop here. So sorry that I exceeded my time a little bit. Thank you for your patient listening.
Thank you, Professor Mohan Naveen sir, for very exhaustive coverage of inflammatory neuropathies. The questions and answers will be taken at the end of the talks and will be moderated by Professor Vinod Puri. Now I invite Dr. V.Y. Vishnu, who is presently Assistant Professor of Neurology at AIIMS Delhi, and he is a Faculty Fellow of International Center for Genomic Medicine in Neuromuscular Diseases, and he is a future leader of Bird Stroke Organization. He has done his DM from PGI Chandigarh. He has many awards to his credit, which include American Academy of Neurology Award, World Stroke Congress Young Investigator Award, Department of Science and Technology Earlier Career Award, and David Sackett Memorial Award. His area of interest include neuromuscular disorders, stroke, CNS vasculitis, artificial intelligence, and evidence-based medicine. Dr. Vishnu will be talking on metabolic neuropathies, and we all agree that metabolic neuropathies, which include diabetes and other metabolic diseases, these are the most common clinical problem in our day-to-day practice. Dr. Vishnu, please.
Thank you, sir. Can you see my screen?
Yeah, yes.
Yeah. So it's disappointing to stop Madhusudan sir. No one gets enough of his sir's lectures. So I wish I could continue hearing him, but I've been hearing his lectures right from my undergraduate times, from MD times, DM times. You know, it's a great honor to be part of this panel of such brilliant experts, and thank you for giving me an opportunity to talk here. So we have around 20 minutes time left to catch up the time. So what I'll do is I have nothing to disclose. So metabolic neuropathy, I mean, it's a broad term. So it depends upon whom you talk to. People can include wide conditions under this broad heading. But more broadly, it's a spectrum of peripheral nerve disorders associated with systemic diseases of metabolic origin. So with a hallmark of peripheral nerves getting altered by structure or function, the myelin or axons due to metabolic pathway dysregulation. A lot of things come under this. Diabetes is the most common cause, followed by uremia, then alcohol-related neuropathy, nutritional deficiencies, hypothyroidism. These are the 5 conditions which I will try to cover. There are a lot of genetic conditions which causes the metabolic pathways also affecting the metabolic neuropathy. I would skip this for this talk. For example, porphyria or the disorders of lipid glycopeptide metabolism, mitochondrial disorders. Some of them maybe Dr. Madhu will be covering in her next lecture. So coming to diabetic neuropathy, it's an audience of physicians, so I don't need to say about the volume or the quantity of diabetes that we have at the current problem in our country, because we are almost the diabetic capital of the world with 75 million diabetes and 138 million pre-diabetes in India. And diabetic neuropathy is the most prevalent complication. So 50% of diabetes will have at least documented diabetic neuropathy, most common being the distal symmetrical polyneuropathy. And so of the expected 9.7 billion individuals by 2050, 1/3 will have diabetes and half of them will have neuropathy. So the burden of problem is quite evident here. And the annual cost is around more than 10 billion in the United States. In fact, there's something which was interesting recently came to me with the cost of during a treatment of a diabetic polyneuropathy and its complications in UK. Diabetic foot disease costs more than the breast, lung, and prostate cancer combined. So in developed world, it is much more. We may not be giving that much care to our diabetic foot and diabetic care patients as much as the cost is not that much evident in our part. So the diabetic neuropathy is associated with increased mortality, morbidity, the neuropathic pain, foot ulcers, and finally leading to maybe due to the worst case scenario of a lower limb amputation. So 50% will have around diabetic neuropathies. Most common 4 presentations are, one is a distal symmetrical polyneuropathy, both large fiber and small fiber can present as a glove and stocking distribution. Then we have a radiculoplexopathy or a radiculopathy, then mononeuropathy, and autonomic neuropathy or a treatment-induced neuropathies can present like that. Major risk factors, the major predictors are duration of diabetes and HbA1c levels. So the duration of diabetes is universal, common for both type 1 and diabetic and both HbA1c, but the metabolic syndrome is major factor for type 2 diabetes. Smoking, alcohol abuse, increased height, and older age are risk factors for diabetes. For painful diabetic neuropathies, females, poor glycemic control, impaired renal function, and high BMI are risk factors. Regarding the pathophysiology, I mean, it affects mainly sensory axons, autonomic axons, and later motor axons. The typical dying back sensory phenomenon is explained because we say that it's a metabolic phenomenon. So it is as distal to the part of the axon. So the central neuron, the cell body is relatively preserved compared to the distal part of the nerve, where the metabolites are less likely to reach initial part. The other one which is likely to be affected initially. But then now the new evidences are now coming up that the whole of neurons are affected in diabetic neuropathy, not just the distal part. It's just the relative how much they are affected that which may be causing the symptoms. So lung-dependent neuropathy, that is more, so you affect the distal part of the legs, then slowly progresses up, and by the time they reach the knee or their hands, gets affected. The hyperglycemia, dyslipidemia, and altered insulin signaling are the major pathophysiology, which causing the hyperexcitability of sensory neurons, which causes the symptoms of painful paresthesias also. So there are a lot of exact mechanisms still not known, but there are downstream injurious pathways associated with all these, and finally microvascular disease also causing neuronal inflammation, oxidative stress, mitochondrial dysfunction, and cell death. So these are the major mechanisms, which I will not go into details of each one of these, but increased glucose. So just to stress the part that not just the glucose, the metabolic syndrome as such. Because when we say about the blood sugar control, and there is a general perception that if you just control the blood sugar, the neuropathy will get controlled. It may be relatively better control in type 1 diabetes. In type 2 diabetes, the control of blood sugars is not directly have that much effect on just alone control of blood pressure, and effect on the neuropathy, both in the prevention and in the outcome of the neuropathy. So the metabolic syndrome as such needs to be managed in type 2 diabetes. There are central and peripheral mechanisms going to the neuropathic pain. We'll not go into these details. So there's a classification of diabetic neuropathies. They are classified into generalized symmetrical polyneuropathies. There are some acute painful distal polyneuropathies like treatment-induced diabetes or hyperglycemia-induced neuropathies. Then you've got autonomic neuropathies. Then you've got the focal multifocal neuropathies and mononeuritis multiplex, or the current term we call as a multiple mononeuropathies. Then you have the entrapment neuropathies, which we may see a double crush phenomenon there. So neuropathies, another classification, grossly you can classify it as an acute painful distal neuropathies. You can autonomic neuropathies, focal or multifocal neuropathies, mononeuropathy or multiple mononeuropathies, radiculoplexopathies, and the entrapment neuropathies. So here, the pathways, this pathway is important not just to say that about the diabetic fulls and amputation, but important to say that it is the two major pillars here happening is, one is the diabetic polyneuropathy and the peripheral vascular disease. So the elephant in the room is the diabetic polyneuropathy, so which we can't neglect. So we can not only just the peripheral vascular and this one is diabetic polyneuropathy, which is the one which downstream effects causes the rest of the problems in a diabetic foot and this one. So we need to identify early and manage them. Clinical features, diabetic neuropathy is initially, the classical one is mainly a clinical diagnosis, may not require an electrophysiology also to diagnose a diabetic neuropathy, presence of signs and symptoms of peripheral dysfunction in patients with diabetes. After other etiologies are reasonably excluded, so that the catch is in that, how can you exclude other etiologies. So the numbness, tingling, pain, weakness, and unsteadiness are the initial symptoms. Usually starts in distally, then spreads proximally. Even the small fiber neuropathy also can have developed early and it's become even in the pre-diabetes in the state. So distal painful symptoms, the burning, lancinating, freezing pain, which is more common at rest than during activity. Large fiber neuropathy can occur later, but sometimes we make a very early onset of the large fiber neuropathy also. And 30 to 50% have neuropathic pain, and they have spontaneous burning feet, allodynia, and paresthesias. Something which is called as the paradox of painful insensitive feet. That painful means at both the time the patient will say that it is insensitive, we have numbness. The same place you will feel that there is a paresthesia also, so, or allodynia also. So both are there in the same area of the feet, same way to the same patient. So there are some diagnostic criteria. For example, Toronto expert panel has classified into possible, probable, confirmed, and subclinical. So possible is just the clinical diagnosis, presence of signs and symptoms. Probable, you have something else. Examination was you have something of reduced distal sensation, abnormal angle reflexes. Confirmed, you have an electrophysiology or some validated measure of small fiber neuropathy, as well like skin biopsy or a thermal threshold testing. So you have an objective measure, you can get it confirmed, and there is a subclinical one. The patient doesn't have, but you have some tests to show that the patient has neuropathy. So Now, normally, you see the glove distribution with the loss of angle reflexes early. Later on, the weakness and small foot muscles and dorsiflexus, the weakness occurs a little late. So when you hear something of an early upper limb involvement, that should be a red flag. It should be either a mononeuropathy related or should be an alternate diagnosis should be thought of. So what are the red flags? In an acute or subacute presentation of a neuropathy, when there's a non-lung dependence, there's a motor predominance, and an asymmetry of neuropathic signs and symptoms, there are some red flags in that. So the common red flags is one thing which mostly when a severe diabetic neuropathy comes is whether a patient has got a CIDP or not, coexisting CIDP with a diabetic neuropathy or not. So when you have a more of a motor involvement proximally, you have a CSF with protein elevated, which may not be 100% true, which we may see in a diabetic neuropathy also. So these are the conditions, and you have a MRI showing a root plexus enhancement or plexus thick or a root enhancement and thickening. These are some signs you may get in favoring of an immune-mediated neuropathy coexisting or over on top of a diabetic neuropathy patient. So investigations, vitamin B12 level is very important. B12 related neuropathy is important, especially in a diabetic patient on metformin for a long period of time, which metformin can interfere with B12 absorption. Thyroid function test, electrophoresis, immunofluid fixations, CSF and genetic testing if you are suspecting a genetic neuropathy in any point of time, or CSF and immune-mediated neuropathy. MRI of nerve roots and plexuses, just as I told before, if you are suspecting an immune-mediated coexisting, it may help you in a clinical diagnosis. There are a lot of differentials, especially alcohol-related neuropathy, nutrition neuropathy, genetic neuropathies, amyloidosis, and paraprotein, depending upon the age group that you're looking at. Basic simple investigations, you look at an HbA1c, B12, along with mesamalonic acid and homocysteine if you want to differentiate between B12 and folate deficiencies. Thyroid function test, electrophoresis, immunofixation, genetics rarely you want to do. Screening, when do you screen for diabetic neuropathies? You screen and at diagnosis you screen, then you annually for patients with type 2 diabetes. If it is a type 1 diabetes, 5 years after diagnosis, and then annually for patients that type 1. You do use a 10 gram monofilament test, which I think all physicians know it. You do a vibration testing using 128 hertz, and clinically you can look at the deep tendon reflexes, your amount of the large fiber involvement at that point of time. Prevention, you say, obviously the easy thing to say is control blood sugars, and so it's a better result, but it gives better results in type 1 diabetes than type 2 diabetes. Exercise is supposed to be preventing, and there are some small studies to show that some weekly structured supervised exercise program might prevent frank diabetic neuropathy in patients with diabetes, but you need to have much more evidence to suggest that. Weight loss is also supposed to have, some people suggest some bariatric surgery in obese patients, but this needs more evidence to say. Management, obviously glycemic control, lifestyle modifications, diet and exercise coupled with optimal lipid and blood pressure control. You manage your metabolic syndrome as a whole in type 2 diabetes. That's the crux in managing diabetic neuropathy. And most important part in managing diabetic neuropathy is the neuropathic pain. And neuropathic pain, that's $1 million question, $1 million business also, how to manage the neuropathic pain in diabetic neuropathies. There are a lot of trials, disease modifying therapies have been tried. Alpha lipoic acid showed some benefit in some small trials, but it's not FDA approved. Bigger trial didn't show any significance. Benfotiamine, some polyunsaturated fatty acids, aldoreductase inhibitors, which some of them are approved in Japan and all, but none of them has big evidence regarding this, and this is not routinely used in clinical practice. Most importantly, the pain management. So you got the calcium channel for 2 delta ligands at the pregabalin and the gabapentins, SNRIs like duloxetine, venlafaxine, and tricycling antidepressants like amitriptyline or triptyline. These are the usual 3 musketeers of group of drugs which are used in managing diabetic neuropathy. So when it's a simple algorithm where most of the algorithms now say that try and avoid opioid analgesics as much as possible, unless in the very late stage and specialized cases or individualized cases where you will really require it. Otherwise, try and avoid opioid analgesics. Try and manage with one of these drugs. Then you do a combination with a first line therapy you try, then you shift to another first line therapy, then you consider combinations of these. So this is in a nutshell an overview of most of the control of the diabetes mellitus. When they're reducing the risk is to try and control the metabolic syndrome. In management, mainly based on the controlling the risk factors to try and control the psychosocial morbidity and other factors, and use the first line drugs of one of these 3 group of drugs, and then try and play around these 2 drugs in a combination, and try and manage the other peripheral vascular complications also, so that you don't try and prevent a diabetic foot. So coming to the next major metabolic syndrome, that is uremic neuropathy. It's common in end-stage renal disease. It's a distal symmetrical sensory motor polyneuropathy caused by the uremic toxins. Develops only patients with a significantly reduced GFR. And in fact, if the patient is not on dialysis, it is a good indication. It's a good frank indication to do or start dialysis. Pathology is severe axonal degeneration with some secondary segmental demyelination. It correlates with the severity and duration of renal failure. It can occur in any age, actually males more than females. It's the only factor that is what is the extent of renal failure. That is in same Dying-back neuropathy. It can have mononeuropathy at compression sites also. The exact pathogens is not known, but the uremic toxins usually occur. The toxins are the one which is trying to causing the damage, and also hyperkalemia also saying some role in affecting the axonal depolarization. So incident onset and slowly progressive. Sensory symptoms to start in the lower limbs, then you get paresthesia as a common, then you get a weakness and atrophy. Progresses proximally, then later on you get an upper limb. Sometimes have a paradoxical heat sensation. Then this lower temperature, you get to feel as a higher temperature. And muscle cramps, restless syndrome, autonomic dysfunction. There are some case reports of GBS-like presentation. It's very, very rare. Mononeuropathies at multiple compression sites, like it could be a double crash, amyloid deposits in carpal tunnel. Sometimes distal ischemia, such as avial fistulas, have also been reported. Nerve conduction is predominantly axonal. You have a lot of differentials for that, depending upon the underlying cause of the renal failure, coexisting diabetes, amyloidosis, this and all. But if the patient is not on dialysis, it's a good indication to start dialysis, and patient significantly improve after dialysis also. So even if patient is on dialysis and failed to give benefit, is maybe an indication to go for a transplant. You try gabapentin 100-200 milligram per day, and additional 300 milligram after each hemodialysis also been tried, and try and have good food care. Then we go to the hypothyroidism. Hypothyroidism, mainly three more common. One is the carpal tunnel syndrome, the most common, and can have a hypothyroid polyneuropathy. Then some autoimmune demyelinating neuropathies may be it's just an association. Maybe IDP, CADP, has been associated with Hashimoto's thyroiditis. Maybe just an underlying predisposition to autoimmune disease. So the CTS, the pathogens is a mucinous infiltration of the perineurium and endoneurium of the median nerve within the carpal tunnel, and clinical features are similar to other causes of carpal tunnel syndrome, and sometimes even precede the features of clinical features of hypothyroidism. So ideally all cases of carpal tunnel syndrome usually screen with the TSH, and you treat the underlying hypothyroidism, and other treatment modalities of CTS should work, but nobody has specifically looked for hypothyroidism and CTS. Anything else different to be done, but should work in less like in other causes of hypothyroidism, unless you treat the primary cause of hypothyroidism also. And pathogenesis is the same. Micropolysaccharide protein complexes in the endoneurium and perineurium, it causing whether it is a primary demyelination, secondary axonal, or axonal secondary demyelination is still not known, but predominantly it's usually an axonal cause. And clinical features are mostly symmetric. The polyneuropathy part is fake. You got a stocking and glove distribution, and with a sensory loss, tingling, and painful dysesthesias. The classical delayed relaxation of the reflexes that we have been learning from our undergraduate times. The severe, rarely you can distal weakness and atrophy is usually rare. It's mostly a sensory symptoms usually. And onset and duration onset and duration is actually the duration of hypothyroidism may be correlating, not necessarily the severity of hypothyroidism may not necessarily correlate with the severity of the neuropathy, but the duration of hypothyroidism is the one which is more likely to correlate. Sometimes, rarely, can cause an isolated small fiber neuropathy. NCS is around showing both axonal and demyelinating changes. Treatment is mainly a high hormone replacement. And the alcohol neuropathy, gradually progressive disorder of sensory motor and autonomous, symmetric polyneuropathy, autonomic neuropathy, and even compression mononeuropathies can occur. Mainly alcoholic neurotoxicity, demyelination with coexisting nutritional vitamin deficiency is very difficult to rule out. Other causes in which maybe nutritional causes also coexist within alcohol neuropathy. Symmetrical and distal, gradually progressive. Got a numbness, paresthesia, burning paresthesias, and pain, weakness, cramps, and ataxia, depending upon if the large fiber neuropathy is there, you can get sensory ataxia. Most common loss of DTRs, especially angle jerk, touch, vibrations, and weakness. It probably presents like a large fiber neuropathy. And then can have multiple compression neuropathy, CTS, ulnar neuropathy, peroneal palsy, Saturday night palsy. It looks at depends upon the patient also. It depends on he's prone to more develop a compression neuropathy. Treatment, there is no disease modifying treatment. Thiamine supplementation is advised to all patients. Improve nutrition, cessation of drinking. Then you get it tried the gabapentin, pregabalin, amitriptyline, or all tried. Unless you stop the insult of alcohol toxins, correct the nutritional part, do a thiamine supplementation, and try and do the symptomatic treatment of these drugs. Nutritional deficiencies or excess causes neuropathies. We all know it. Correction of abnormality should cause resolution. Always look for medications, environmental exposure, hobbies, alcohol consumption. Some vitamin deficiencies have genetic origins also. You should just keep in mind some of the vitamin B12 deficiencies have cobalamin genetic causes also. So if you don't find any other causes, if you have a question, something else, you should think of genetic causes also. We look at some of these vitamin deficiencies. B1 thiamine deficiencies, dry beriberi, symmetrical peripheral neuropathy can cause sensory and motor impairment. It's been in the Western world is mainly with the weight loss surgeries, total parenteral nutrition, loop diuretics. You treat with the parenteral administration of thiamine if patient is critically ill. Riboflavin, pure riboflavin is very less. Usual causes are starvation, anorexia nervosa, malabsorption, avoiding dairy products, long-term use of phenobarbital and other barbiturates. There are some inborn errors of metabolism and even a riboflavin transporter like BBVL, something which looks like a Madras motor neuron disease with the hearing loss and the bulbar and Honsley said riboflavin transporter deficiency. So these are all some genetic causes of riboflavin deficiency also. So overt deficiency are rare. So sometimes severe deficiency can present with a seborrheic dermatitis, microcytic anemia, and seizures. Mild deficiencies can present with neuropathy also. There are some genetic causes also which causes pyridoxine deficiency. Some like inborn pyridoxine responsive seizures. Some drug inducers which more likely to see with isoniazid acid, penicillamine, hydralazine, and levodopa, carbidopa also. So toxicity in the other side of pyridoxine vitamin deficiency, toxicity of more than 250 milligram per day, even can see more than 100, 200 milligram per day also. You can peripheral neuropathy, dermatosis, photosensitivity, dizziness, neuropathy. Sometimes severe toxicity can looks like a ganglionopathy also. B12 deficiency is most common, which I think we all see and manage. Vitamin B12 deficiency, symmetric paresthesias, numbness, and gait problem. It can present with a myeloneuropathy, which can cause a subacute combined degeneration involving the posterolateral column of the spinal cord. Because the upper limb and lower limb simultaneous one. So that's the one you suspect a coexisting subacute combined degeneration, not just the typical glove and stocking involvement. And unexplained anemia, macrocytosis, pancytopenia, hypersegmented neutrophils, unexplained neurological psychiatric symptoms, strict vegan, or condition that that may affect with the absorption. Some autoimmune disorders like thyroiditis, vitiligo, or those taking chronic metformin therapy, or GI symptoms such as sore tongue and diarrhea. These are this is the typical scenario where we suspect a B12 deficiency. There are a lot of causes for even in gastric abnormality, small bowel disease, pancreatic, diet-based, and drugs that block or impair absorption. Then there is some genetic causes also for B12 deficiencies. So diagnostic testing, so other than doing the B12 level, so level usually we do if you can afford if you have the facility to do MMA and homocysteine also. If MMA is increased, both are increased, B12 deficiency is confirmed. If MMA is normal, homocysteine is followed, or both are normal, then if it's a B12 level, so the borderline level is most unlikely that to be a B12 deficiency. So the treatment is 1 milligram IM. You give for weekly, for month, and monthly. Try and find out a cause. If you can't find out a cause, you may give it for a long period of time. There are some conditions which are not critical in neuropathy. So Matthew sir has already discussed in this initial part. Toxin-related neuropathies, a lot of toxins like arsenic and others can cause severe neuropathies. Whether they come under the category of a metabolic neuropathy is a little controversial, but still they also can be considered. So I'll conclude by saying that metabolic neuropathies are mostly treatable neuropathies. There is a significantly affect the quality of life. That's the most important part, because a diabetic neuropathy patient, whatever you do, if more than the diabetes under control and most of the cardiac or other part, maybe the neuropathy is the one which is affecting the mostly the quality of life. So that symptomatic improvement is more important. Even if you control the blood sugars and if you can't relieve the pain or neuropathic pain, they may not have a good quality of life. They can coexist with immune mediated and hereditary neuropathies. Just all neuropathies in diabetes are not diabetic neuropathies. So you find out the red flags and you look for other treatable causes inside the diabetic neuropathy. And diabetic neuropathy is the most common complication of diabetes, and you need to work on it. And most of the important risk factor for a diabetic foot also need to be managed as such. And management of diabetic neuropathy is a cost-effective measure for preventing complications. It's worth, regarding the cost that can incur to the patient in the future, it's worth considering putting an effort on managing the diabetic neuropathies. Thank you.
Thank you, Dr. Vishnu, for covering metabolic neuropathies in detail and taking care of time also. Next, I invite Dr. Madhu Nagappa, who is an additional professor of Department of Neurology at Newman's, Bangalore. Her area of interest is primarily neuropathies, which include Guillain-Barré syndrome, carpal tunnel syndrome, leprosy, alcoholic and toxic neuropathies. She will be covering very important topic of inherited neuropathies and talking about when to suspect inherited neuropathy, Charcot-Marie-Tooth disease, and various other types of hereditary neuropathies. Ma'am, please welcome to this forum.
Good evening, respected moderators, President Ian, and all the panelists. So what I have done is that in order to avoid any technical glitches, I have just recorded the presentation about half an hour back. So I will share screen for the recorded presentation. Good evening to one and all. At the outset, I would like to thank Professor Nirmal Surya, President IIN, for giving me this opportunity to speak on inherited neuropathy. Among the neuromuscular disorders, inherited neuropathies are not so rare, the overall prevalence of CNPs being about 1 in 2,500 individuals. About 1/3, and according to some studies, even 1/2 of the patients refer.
Hello. Dr. Madhu, any issue? You are not able to connect?
Hello.
Yeah.
Hello.
Digital India,
You are
please
not
help her
able
out.
to hear, sir. Are you not able to hear my screen, sir?
No, we are not. We are seeing a small screen.
Okay, sir. I'll just share the screen once again.
Sound.
At the outset, I would like to thank Professor Nirmal Surya, President IIN, for giving me this opportunity. Among the neuromuscular disorders, inherited neuropathies are not so rare, the overall prevalence of CNPs being about 1 in 2,500 individuals. About 1/3, and according to some studies, even 1/2 of the patients referred to the peripheral neuropathy clinics in the specialized centers are suspected to have an underlying inherited cause. And based on whether the neuropathy involves the motor, the sensory, or the autonomic.
Your voice is not audible. Could you?
And whether there exists evidence for a multi-axial neurological involvement with involvement of both.
Could you increase the volume, please?
Or when there is. So you're not able to hear my voice, sir? I'll just increase the volume, sir. the liver, the kidneys, there are different phenotypes that have been recognized, and some of them are really complex. But for today, given the limited time, I'm going to focus primarily on the CMTs, where the neuropathy is the sole or the primary part of the phenotype. Coming to the pathomechanisms, abnormalities in several molecular and cellular mechanisms that control the myelin formation and stability, membrane trafficking, intracellular protein sorting and quality control, mitochondrial dynamics, protein biosynthesis are some of the mechanisms that are suspected to lead to alterations in the structure and function of Schwann cells or altered axonal transport and function. Now, there are several ways by which CMTs can be classified. They can be classified by the age of onset, the patterns of inheritance, and Dick and Lambert proposed the first classification of the CMTs and other inherited neuropathy diseases based on the inheritance patterns, the electrophysiology, and the pathological characteristics. Since then, with the technological advances, the classification was based on the genetic abnormality, and the alphabets were designated for the individual genetic abnormality. But we have only 26 alphabets, and the genetic causes have now exceeded 26 letters, and so there is no longer a scope for the individual unique alphabet match. You can also see that there is some degree of lack of concurrence among the nosological terms that are provided by the different author groups. For instance, at present, the recessively inherited demyelinating neuropathies have been designated as CMT4, while in the earlier classification, HMSN4 referred to actually Refsum's disease. Similarly, HMSN3 or the Dejerin-Sotas disease, which referred to a phenotype with onset in infancy and childhood and a severe generalized neurological deficit, has since then been shown to cause by mutations in a number of genes, including the PMP22 and the NPC, which actually are the CMT1A and 1B. So, to avoid confusion, this term, that is HMSN3 or Dejerin-Sotas disease, has been removed from the subsequent classification. So at this point, one may think that it is most appropriate to classify the CMTs based on the genetic abnormality. But a significant overlap has been recognized not only in the inheritance patterns, but also in the clinical and electrophysiological phenotypes. For example, mutations in MPC cause demyelinating as well as axonal neuropathy. Likewise, mutations in GDAP1 have been known to cause both recessive forms as well as the dominant forms of CMTs. So, a revised classification has been proposed, and autosomal dominant demyelinating neuropathy is designated like this in the revised classification, where AD refers to the autosomal dominant mode of inheritance, DE refers to the demyelinating neuropathy, and this is the genetic abnormality, which is the PMP22 duplication. Coming to the clinical features, the age at onset ranges from infancy to elderly. A fraction of subjects do develop neuropathy from the neonatal period or the infancy itself. Majority have onset within the first 2 decades of life. But here, you must remember that CMT has an extremely insidious onset and a very slow progression. Therefore, it is very difficult to exactly pinpoint the age of onset. Common clinical features are the presence of distal symmetrical weakness, wasting, areflexia, and deformities that are much more pronounced in the lower limbs as compared to the upper limbs.
Madhu, your
Patients
voice is
typically
very,
manifest
very
with a
low.
high-steppage gait, as seen here. You can see that because of the weakness of the
You
ankle
need to
joint
increase the
flexors,
volume. It is very low.
the patient lifts the foot high above the ground in order to steppage gaits. Who is in his teenage assistance to walk. And on the other hand, this is a 40-year-old gentleman who's chair-bound and cannot walk at all. Life expectancy, however, is not affected in these patients. Now, a fraction of subjects that develop neuropathy in the neonatal period or during infancy. This early onset CMTs includes the congenital hypomyelinating neuropathies and the Dejerine-Sotas disease as mentioned earlier. Affected individuals typically manifest with delay in motor milestones, foot deformities, and severe phenotypes even have neonatal hypotonia, feeding difficulty, and respiratory compromise.
Madhu, I will request
What are
you
some of
if
the
you could take
deficits
live
present
from the slides. I think you were better audible than your video. People would definitely want to listen to you. You can go to your PPT and start the slide from there and can speak.
symptoms and signs are relatively less prominent. About 20 autosomal recessive demyelinating CMT or CMT4, as I mentioned earlier. In this paper, we provided the data of a cohort of patients of Indian origin with SH3-PC2 variations, and we have highlighted the phenotypic differences from the other cohort. So the phenotype of this neuropathy was characterized by female predominance and demyelinating electrophysiology, which is similar to that reported by other cohorts. However, in other cohorts, it has been reported that all patients with SH3-TC2 usually have an early onset neuropathy, significant deafness, and severe scoliosis, but majority of the patients in our cohort did not have these features. And more notably, even though majority of the patients were not symptomatic for the hearing impairment, brainstem auditory evoked potentials, that is, or they disclosed abnormalities in all the patients uniform. Now moving on, let us take a look at this one more unusual patient who had to be tracheostomized at 5 years of age for stridor. So the onset of symptoms was with motor developmental delay and difficulty in walking from the time this patient started walking. He developed respiratory difficulty and stridor at 5th year of life. He was detected to have vocal cord palsy, and subsequently he developed increased difficulty in walking, upper limb weakness, and progressive foot deformity. As you can see here, he was born to consanguineous parents. He had two younger siblings. The last sibling had motor delay and mild difficulty in walking, which was less prominent as compared to the proband. So here is the proband. You can see that he has severe foot deformity like a club foot, and he tends to walk on the dorsal surface of the foot. He has a high steppage gait. This is the second sibling. You can see that she is unaffected. And this is the third sibling who had mild neuropathy. You can make out the foot drop gait as this patient continues to walk. Now, genetic testing showed pathogenic mutation in the MTMR gene, which is known to cause neuropathy with vocal cord palsy. Now, this is not exactly a unique phenotype because vocal cord palsy can also occur with mutations in other genes. So, which goes to say that additional symptoms, beyond the neuropathy phenotype, such as involvement of the cranial nerves and other portions of the neuraxis, have been described in patients with CMT. These and some examples include pupillary abnormalities in patients with NPC mutations, optic atrophy in MFN2 mutations, hearing impairment in a number of genetic abnormalities. So this picture here gives a glimpse of the some of the additional craniobulbar and other neurological features and the corresponding genetic abnormalities. Now, let us take the example of this 55-year-old gentleman from Andhra Pradesh. His first clinical manifestation was an acute onset of quadriparesis without bowel and bladder involvement at 11 years of age. Now, the weakness rapidly progressed over 24 hours, but he recovered spontaneously over 15 days. At the age of 26 and 31 years, he developed transient hemiparesis that spontaneously improved over 30 minutes. And from 23 years of age, he developed slowly progressive difficulty in gripping footwear, gripping the pen and writing, as well as followed by difficulty in getting up from the sitting position. When he came to us, examination revealed the presence of hammer toes, press cavers, wasting and weakness of distal muscles, global areflexia, and impaired joint position sense. The patient could walk independently with a wide waist and a high steppage gait. This patient was born to non-consanguineous parents and there was no history of similar illness in the family members. Nerve conduction studies showed evidence of demyelinating neuropathy and evaluation for other vascular and vasculitic causes were negative. Now you can see the brain MRI which showed bilaterally symmetrical confluent hyperintensities in the periventricular white matter, particularly in the posterior part of the corpus callosum and the splenium. Genetic testing showed evidence for a likely pathogenic variation in the GJB1 gene. So this is an unusual manifestation of CMT1X with leukoencephalopathy and transient CNS involvement. Uncommonly, in these patients, rather than neuropathy, the CNS involvement could be the first manifesting feature. So GJB1 neuropathy should be considered in the differential diagnosis of patients presenting with a stroke-like episode, apart from the classical mitochondrial disorder called as MELAS. Not only this, because this is neuropathy, one would expect that the reflexes would be absent, like this. But some patients have been known to have brisk reflexes, which means to say that pyramidal signs can also coexist. Recall that this phenotype was earlier designated as HMSN type 5 in the original Dick and Lambert classification. At this point, you may also recall that there are a subset of hereditary spastic paraplegias, which are the complicated HSPs because they are associated with neuropathies. So CMT with pyramidal signs and HSP with neuropathy are now shown to be a continuum of disorders. Thus, these are long axonopathies that affect the motor and sensory pathways, while CMTs predominantly affect the peripheral nerves. The HSPs predominantly affect the corticospinal tracts and the dorsal columns. It is now increasingly recognized that both these phenotypes, they are in a continuum and they have many similar molecular pathologies and overlapping genetic abnormalities. Now this picture gives an overview of the different neuraxis and the several different organ systems that are affected. It would be difficult to go into the details. So we'll move on to the electrophysiology. Nerve conduction studies are essential to confirm the clinical diagnosis and further categorize the patients into demyelinating and axonal phenotypes. A median nerve conduction velocity of 38 meters per second is commonly used as cutoff for differentiating the demyelinating from the axonal type. In addition, an intermediate form where the nerve conduction velocity ranges from 25 to 45 meters per second has been recognized by some authors. And based on the degree of slowing, the CMTs have further been classified as very slow, slow, and intermediate subtypes. This subdivision is useful for selecting the genetic testing for the patients with inherited neuropathies. Again, here it is to be noted that it is the amplitude of the recorded potential that reflects the degree of axonal loss and that correlates with the clinical disability rather than the degree of slowed conduction velocities. Now, as can be expected, the slowing is uniform and diffuse in inherited neuropathies, unlike the acquired etiologies where the changes are non-homogeneous and asymmetrical. Conduction blocks, temporal dispersion are rare in inherited neuropathies. But this is not always the rule. In GJB1 associated neuropathy, the motor conductions show non-uniform and heterogeneous findings within a single nerve as well as between multiple nerves, with the velocity being more significantly affected in the median nerve as compared to the ulnar nerve. Temporal dispersion and conduction blocks can occur in GJB1 neuropathy. And this internerve heterogeneity is more prominent in females as compared to males who have more severe and more uniform reduction in the conduction velocity. Now, this is the latest technology, imaging of the peripheral nerves by MRI and high resolution ultrasound. And we can see the markedly and diffusely enlarged nerves. The nerves are enlarged throughout their length. Even the proximal components such as the plexuses and the roots are markedly enlarged. Now, this finding has been consistently demonstrated in CMT1A. It correlates with the clinical disability as well as the electrophysiological parameters. But in the other CMTs, the enlargement of peripheral nerves is not as remarkable and not as consistent across patients. At the molecular genetic level, as mentioned earlier, CMT is a very heterogeneous disorder with more than 100 genes being implicated, and the number is constantly increasing, and all possible modes of inheritance have been recognized. It is important to order the right test. In a patient with demyelinating neuropathy, the commonest abnormality is PMP22 duplication. So this can be detected by using a simple test such as MLPA, which is quick and inexpensive, and this can be missed out in the exome sequencing. However, the gold standard technique is Sanger sequencing, but there are too many genetic variants that have been implicated in CMT, and there are no specific phenotypic distinguishing features to select which gene to sequence by Sanger sequencing. So the newer high throughput genetic sequencing techniques, which are referred to as the next generation sequencing technology, are now widely available, and they are very efficient. So they are the test of choice once the copy number variations in the PMP22 gene have been excluded. The caveat is that they lead to the identification of a large number of variants of uncertain significance and whose causal relationship with the phenotype is often unknown. Now, we performed a study on a fairly large cohort to detect the genetic basis of their CMTs. And this study led to the identification of a large number of genetic variations. They were pathogenic or likely pathogenic in about 87%, but in addition, we also detected a large number of novel variants and variants of uncertain significance. So these are the genes that are implicated in a number of cellular functions, such as growth and differentiation, endocytosis, tRNA synthetases, intracellular calcium homeostasis, the ubiquitin proteasome system, among others. So given here in this one study itself, you can see the large number of genes that are implicated in CMT. So it is very difficult to precisely pinpoint which is the genetic abnormality based on the phenotype because the clinical features are rather overlapping. Another important finding in the study was that in 11 patients, there were mutations in multiple genes that are implicated in neuropathy. So this is an upcoming concept that the more the number of genetic variations, the genetic burden is increased, and this may impact the phenotype. So NGS or exome sequencing would be the test of genetic testing of choice in patients once the copy number variations in the PMP22 gene have been excluded. Now, the role of biopsy may appear to be redundant in the era of modern genetic studies. However, one must remember that biopsy does have a role in select situations. It helps us to understand the functions of the mutated genes and to some extent the pathways leading to disease, especially when variants of uncertain significance are identified. It also helps us to suspect a genetic etiology and direct the genetic testing in sporadic cases, especially when they are mistaken for inflammatory neuropathies when they have onset in adult life. The findings in biopsy can be either specific or non-specific. Non-specific findings include demyelination, remyelination, and axonal loss. Whereas there can be some specific findings such as onion bulbs in CMT1A, tomaculae in HNPP, uncompacted myelin and myelin outfoldings in those with MPC mutations, mitochondrial abnormalities in patients with GDAP1 and MFN2 mutations, and giant axons in patients with giant axonal neuropathy. Besides these tests, that is the electrophysiology, the genetics, and the histopathology that are used for establishing the diagnosis, it is also important to perform the necessary investigations to look for other concomitant illnesses that may worsen the neuropathy. such as diabetes mellitus and nutritional deficiencies. Also, appropriate investigations need to be carried out to look for other organ involvement because some of these systemic complications, when treated in a timely manner, have a good prognosis, such as glaucoma, renal failure, etc. Coming to the differential diagnosis, the other element disorders such as spinal muscular atrophy, distal myopathies, CIDP are the common differential diagnosis. They can be recognized by meticulous clinical examination, electrophysiology, as well as by the relevant biochemical and pathological studies, imaging, and of course, genetic study. Coming to the treatment, we all know that targeted or disease-specific treatment is at present limited, though there are a number of pharmacological therapies that are upcoming and are in the pipeline. But what can be done is active physiotherapy and a judicious use of orthotics that helps to maintain the muscle strength, improve the joint flexibility, reduce the fatigue, pain, stiffness, and deformities, and thereby improve the quality of life in these patients. Apart from this, one has to also anticipate certain complications and treat them efficiently. Respiratory compromise, as I said, is very rare. It arises either from severe neuropathy, very rarely, from the involvement of diaphragm or spinal deformity. Some patients experience worsening of neuropathy during pregnancy, and apart from this, there can be some pregnancy-related complications such as abnormal fetal lie or postpartum hemorrhage, and these may necessitate some emergency intervention on a case-to-case basis. But what is most important is that drugs with neurotoxic effects, classical example being the chemotherapeutic agents, should be avoided in these patients so that the neuropathy is not worsened. The prognosis is straightforward. These are progressive disorders, and there are a number of rating scales and some upcoming biomarkers of progression that indicate that this is a progressive disorder. The speed of progression is varied, but the life expectancy is usually not affected. So to conclude, CMTs are characterized by progressive weakness, wasting, and deformities of the distal extremities. They have a wide spectrum of phenotypes with varied age at onset and severity, and intrafamilial variability, as well as atypical presentations. They, together with a number of other systemic and neurological features that are quite unrelated to neuropathy, that create a complex phenotypes. Judicious use of genetic testing establishes the diagnosis in these patients and facilitates genetic counseling as well as recruitment into upcoming clinical trials. The relatively low frequency of the commonly implicated genes in our population warrants search for abnormalities in other genes in order to establish the genetic diagnosis in our Indian population. And also, the future research should focus on the basis for the phenotypic heterogeneity, including the role of intragenic modifiers. With this brief note, I conclude my talk. Thank you.
Thank you, Dr. Madhu. Now the session is over, and may I request all the four speakers and the moderator, Dr. Vinod Puri, to conclude the session along with the answering the questions which are available in the chat box.
So I'm going to find the chat box.
Dr. Puri, sir.
Yeah. Thank you, sir. There is a question from Partha Ray. Please explain the B6 paradox. I don't know what does it mean, in fact. He said, please explain the B6 paradox.
B6 paradox.
Yeah. But he didn't explain what precisely wants.
Dr. Vishnu, can you answer?
No, this will go to Dr.
Madhusudan.
Now, in fact, I did not hear the question. Can you, sir, can you tell the question once again? Ask me the question. Vinod Puri is my question.
Please explain the B6 paradox.
Vinod, let the moderator ask the question to me. I think your speech is quite interrupting.
No, this is he says excess and deficiency, B6 deficiency causing neuropathy. He says B6 deficiency also causing neuropathy. And
yes. Yeah,
The
now I
basic of
understood the question.
ganglion.
Yeah. Now I
Primary
understood.
of,
Yeah,
now
understood.
the,
Yeah.
yeah,
What you said is the basic deficiency as well as the increased levels of basis intake also going to cause neuropathy. The latter one mainly ganglion neuronopathy causing a sensory ataxia. Why? If you ask me the explanation why it is so, I do not know. Probably Vishnu may be able to help me in that. Vishnu, can you answer that question for me?
Vishnu? Where is Vishnu?
Vishnu has left? Or Vinod Puri, can you answer that? I don't know. Why it's so? Why is it paradox?
Deficiency would not know the mechanism why those of the ganglion get involved in the effect deficiency, but definitely get involved. A person may have the intoxicated feature of ganglionopathy can occur. Deficiency, of course, mechanism well known as that the response for the deficiency. That gets corrected with that. But exactly the mechanism responsible for the loss of ganglion, we do not know. We do not know exactly how it happens.
Okay. Thank you, Puri.
Vishnu is also here, right?
So I'm sorry, I missed the question. Can you?
Vishnu, I was asked the question, why
Okay.
basic deficiency causing neuropathy as well as basic toxicity causing neuropathy?
Yeah,
So,
that's I mean, that is called the basics paradox. So there is a study in 2017 which they did something. So they say that in the high dose of pyridoxal, that means more than 100 milligram, it can affect the pyridoxal L-phosphate, that enzyme mechanisms through that thing, high dose of pyridoxal. That's what they exactly reason I don't know. There is a paper on 2017 that the title itself is called B6 paradox. So they try to do a mechanistic studies to find out why high dose of pyridoxine causes this one. I think that paper was provoked by usually by the EMA keeping a tap on the 25 milligram as the highest dose of pyridoxine to be used. So they found that more than 100 milligram, that means 4 times that dose, it can affect the PLP enzyme and cause something of the at the molecular level so that they affect the caspase enzymes and some other enzymes. But exactly, I don't remember the correct pathway of it.
It has predilection for the dark of ganglion. Your predilection for the dark of ganglion.
Yes, sir. Why it predisposes to dorsal ganglion, I also don't know.
That's the only question that's there in the box. He's saying, is there a genetic reason? How does the get affected? We do not know exactly how it gets affected, but it does get affected. Is there a genetic reason for that? We do not know at the moment. At least we do not know at the moment. Maybe Vishnu may be knowing better.
At present, we don't know. And genetic factor, we can't predict at this point of time whether it is there or not. So, see, neuromuscular field is always has this enigma of why some part are predominantly more affected and some part are not affected. For example, that is part of even a very basic question of why muscle disease affect proximally, why not distally. Even that question is very. If you could look into the mechanistic purpose, that question itself is not clearly answered. So we don't know why most of the myopathies affect proximally and not distally at what point of time. So at present, to say it is some genetic predisposition is too premature at this point of time, because we have a temporal correlation with the dose. It's a dose once we have clear evidence of a temporal association. So most likely due to drug, whether a genetic predisposition is there, at present we don't have evidence to say that.
Vishnu, I have one more question with you. Many people who have diabetic American neuropathy, they also have renal involvement, uremia in addition, and their hemodialysis. How to manage this is a practical problem. How to manage neuropathy in such people?
Yeah,
their syndromes also there. They have diabetic neuropathy, they have uremic neuropathy. How to manage it?
So if the question is like if there is a coexistent diabetic neuropathy and uremic neuropathy, one good part is that if it is a significant amount of uremic neuropathy component, it will usually respond to dialysis. So dialysis is uremic neuropathy is a strong indication for starting the dialysis or renal replacement therapy or dialysis or renal transplant, whatever. So if you look at the series of patients who are undergoing renal replacement therapy and see most of the patients have at least electrophysiological evidence of neuropathy at one point of time. So, but they are usually mildly symptomatic if you are in a good renal replacement therapy. Uremic neuropathy will not be that much symptomatic. So if you have a coexisting diabetic neuropathy, obviously a double crash, symptoms may improve. The symptoms may worsen. Treatment wise, other than renal replacement therapy, conventionally how you treat a diabetic neuropathy, those things can be given. Only thing, gabapentin 300 milligram dose can be given post dialysis. That is the one thing which we can try it out. Yeah.
The problem starts coming here. Most of the people who are on medication after dialysis get removed by dialysis. You have to reload the medication.
Yeah. So that's why they say that you have to give the gabapentin after the dialysis. So that may help. But these are all symptomatic treatment. Unless we have a disease modifying therapy, we can manage symptomatically at this point of time. Yeah.
Thank you. Thank you, Vishnu. Vishnu, one more problem.
Yes.
People with metabolic dystrophy, they also neuropathy. How to manage such people?
I didn't get you, sir.
Patient with hereditary metabolic disorder like metabolic dystrophy, they also have neuropathy. Adrenal dystrophy, they also have.
There are a lot of. I mean, not just metabolic. So I didn't go into the inherited metabolic disorders. It's a big area to start off with. Inherited metabolic disorders causing neuropathies. So any neuropathy, there are two. I mean, there are two conditions. One is a disease modifying, and one is a symptomatic treatment. If there is a disease modifying, the problem with most of the times neuropathy with more conditions is that even if you modify the underlying pathology, you have a significant damage to the nerve, you may not 100% reversal may not be there. In this metachromatic leukodystrophy or any other inherited genetic disorder, where there's no significant disease modifying treatment is not available. So in that case, they have to be treated like a symptomatic treatment if they have symptoms. So if they have clinical neuropathic symptoms are there, most of the time, sometimes metabolic leukodystrophy may not have it. May electrophysiology, we may see a demyelinating neuropathy. They may not be clinically, it may be spasticity and human signs may be more prominent than the neuropathic symptoms. If there is a clinically symptomatic involvement, we can treat it. Otherwise, if there is a significant neuropathy affecting the foot care, those things could be managed as like you treated as Charcot-Marie tooth disease.
Thank you, Dr. Vishnu. There's no other question. There's two more questions also come.
There is a question called I don't know if it's come now or can IVIG benefit generalized diabetic sensory motor polyneuropathy over 4 to 6 months? That was answered. I'm not sure.
There's a question about Sarabjit Singh. How can you differentiate that from CASP? This question goes to Matthew. Matthew. Dr. Matthew, there's a question for you. How can you differentiate that from CSP? Dr. Matthew, can you listen to me?
Can you ask the question once again? Your voice is breaking.
How can you differentiate that from CSP?
Now, if I understand correctly, the question is how to differentiate DATs from sensory neuropathy.
CISP, sir. I think the question is DATs versus CISP.
That will answer. Now you understood the question. Now, DATs is a distal sensory involvement demyelinating. So the demyelinating features are distal. You find absent snaps and or delayed snaps. On the other hand, the snaps are normal in CASP. In CASP, the deletion is distal to proximal to the ganglion, so the snap will be entirely normal. The only way to find out a lesion proximal to the ganglion is either do an SSCP or you can do H reflex if from the tibial nerve. From the other nerves, H reflex is not usually done. This is the only way to diagnose that thing. Second thing you can look for enlargement of the roots by MRI and the enhancement of the roots by the contrast MRI. In the DATS variety, it's only this, it's only lesion is confined to the distal part. They present with distal sensory loss, and unlike CASP, which is asymmetrical, can affect any part of the body, even the trunk, upper limb, everywhere can be affected in a symmetrical fashion. Secondly, the electrophysiological, as already told you, it's a distal demyelination. Third point is that they don't have enlarged roots or elevated states of protein. Then that's always you have to keep in the mind the possibility of an IgM associated DATs where the anti-MAG comes under the category.
There's one more link question again from Partha, and he says paranodopathy and nodopathy. When should we give rituximab in preference to IVIG or PLEX? Should we include NF and CST routinely for AIDP patients?
And can you Vishnu again? I think Vinod Puri's voice is breaking. Had some problem with his bandwidth.
Yeah, I think the question was, sir, regarding the paranodopathies.
Yeah.
When do you give rituximab? Whether you should give early or which antibodies you prefer to give rituximab earlier in paranodal antibodies?
In fact, I mentioned that talks, the antibodies related to contactin, Casper and contactin complex and the NF151, they respond to rituximab. But the sad part of the story is that these antibodies we cannot check now in India. I don't know. Vishnu, do you know whether any place where these antibodies are being...
No, we have sent few samples to Oxford. In the Oxford lab, I think if you can I think we in the samples which we sent was it came negative. But at the Oxford University, the neuroimmunology lab receives samples across the world. If you can send through FedEx, only thing is you have to reach the sample in the normal temperature. You should reach within 72 hours, and you make the payment. I think they will give the reports in 2 to 3 weeks. That's the only area which I know they're doing samples. Okay. I don't think anybody in India is doing it.
Okay. The idea is that if in those situations where you find that your CADP is not responding to a treatment, or AADP you find that again responding to a treatment, it may be a paranodopathy manifesting as an AADP or an acute presentation of CADP, or if it is a CADP, you're not responding, you have to keep this possibility in the back of the mind.
And also, sir, if it is very rapidly progressive AIDP, within 1 day, patient is in ventilator. It's in 6 hours, 12 hours, patient worsens and put into a ventilator. So that also one condition I think.
Exactly. That is I am about to tell that when there is a rapid progression, any atypicalities in the evolution, the patient does not respond to the first line immunosuppressant drugs. Again, keep this possibility in the back of the mind.
Yeah.
And if necessary, I have seen AADP responding to steroids and not to IVIG, because the one child came with a typical AADP, electrophysiologically confirmed, serious study, but severe pain. The child is severe pain, not able to walk. The child did not improve with IVIG. So I put the patient on IVMP, immediate prednisolone. Next day, you can believe me, the video is with me. Child started improving, pain subsided and started walking. So these are all things which are not conventionally mentioned in the textbooks. But as Vishnu was telling, when there is a rapid progression or any atypicality, you have to keep the back of the mind. And of course, you have to go out of the way, not out of the box and treat taking rituximab or IVMP in those situations.
So we have treated a couple of patients with rapid progression, within 24 hours CVS on ventilator, who didn't respond to IVIG or plasma, both plasma exchange and IVIG was given steroid, given rituximab. Patient has improved, but to say, we didn't get that dramatic as such that we have said, but unless we do an RCT, we can 100% can't be sure that because of rituximab. But rituximab should be considered in any patient with any typicality that you said. It's worth giving a shot.
Yeah, right.
There's one more question by Nirmal Pandey. He says, can IVIG benefit generalized diabetic sensory motor polyneuropathy if given monthly over 4 to 6 months?
Diabetic polyneuropathy, I don't think IVIG has got any role, except probably maybe in a diabetics amyotrophy, what we call as a lumbosacral radical plexopathy, where the hypothesis is microvasculitis. Even the Peter Dick's trial on few patients, which he didn't publish, it was only in an abstract. It was published in an abstract, but even that didn't show any much significant. But IVIG, it could be useful. We have a lot of people are using in diabetic amyotrophy IVIG. One reason whether because they don't want to give a pulse prednisolone and sugars are likely to worsen. So that is one point maybe given you IVIG. But even having said that, the evidence for IVIG in diabetic amyotrophy is also very weak. But since the hypothesis, at least we have some biopsy evidence of microvasculitis from the Peter Dick's studies in the late 70s and 80s, that microvasculitis is involved. It is maybe worth trying in IVIG in diabetic amyotrophy or a lumbosacral radical plexopathy. Other than that, in IVIG role in plain diabetic neuropathy role is limited. Maybe a mononeuritis multiplex like presentation of a diabetic, where the same pathophysiology is being proposed of a microvasculitis, or if you are suspecting a concomitant immune-mediated neuropathy along with diabetes, it may be worth giving a try. But to purely giving IVIG in a diabetic neuropathy, the evidence is very weak.
No, in lumbosacral plexopathies, radicular plexopathies, and even though there is no control studies and everything, many case reports are there showing the IVIG as well as IV major prednisolone is effective. I personally am giving regularly in the sense that not the one ordinary garden variety of plexopathy. Those who have got severe pain, you are resistant to all your neuroanesthetic agents, and it's got a weakness of the corticeps. They do improve with IVIG.
Yeah, and the pain also significantly improves.
Comes down.
It's like a Tolosa hunt. When you give a
exactly
steroids, the pain going away, it's a good clue that the patient is responding.
Yeah, those situations we can try.
This could be CIDP co-resistant with diabetic.
Yeah, but they are all acute presentations.
Vishnu, one more question for you. Is the isoniazid treatment and optic neuropathy has a common link of B6?
So I didn't hear the question. The voice got broken up.
Is the isoniazid treatment in case of tuberculosis and optic neuropathy have a common link of B6 deficiency?
I mean, if I hear it correctly, whether isoniazid will cause optic
isoniazid and optic neuropathy have a common link with B6 in treatment diabetes and treatment of tuberculosis?
No, I'm not able to. I couldn't get it. I mean, anyone else could hear what the question was?
No, he says case of tuberculosis, who's an isoniazid. He develops optic neuropathy. Is there any link? If it's a link, is B6 is a common link?
I mean, if you say that the isoniazid-induced optic neuropathy is due to B6 deficiency, that's what. Yeah, well, it may be. I mean, that is one of the reasons why we're giving pyridoxine is due to that. Whether isoniazid causes optic neuropathy mechanism is directly due to pyridoxine, which I am not aware. So, Dr. Madhusudan sir can maybe.
No, I also not aware. The ethambutol can produce optic neuropathy, not IMA.
Optic neuropathy comes very soon. The optic neuropathy, we don't know. That's all. These are all for the old questions. We don't have any more questions. Yes. There's one more question. He said that Dr. Prasad is basically must be talking regarding steroids. He said Prasad firmly believes that DBS trials with MEP were not purely conducted to show lack of response in ME patients.
I think anybody give me funds and an ethics approval, I will do the trial. I need two things. One is funds. Funds is still somehow we can get it. Get funds. Two things is an ethics approval to do a control arm, give steroids and not IVIG in plasma exchange. If that two things, if we can get, I personally believe the trial should have been done long back. Our forefathers, our experts during the yesterday years should have done that trial. We didn't do it. Now we are stuck. Now, no, I don't think any ethics committee will give approval to do a trial with a control arm of steroids and a regular arm of IVIG or plasma exchange. And if you give steroids over and above IVIG, because both receiving IVIG or plasma exchange, I don't think steroids will have some ceiling effect. I don't think we'll show over and above effort of IVIG or plasma exchange. But I believe that the steroids will work as good as IVIG or plasma exchange, but there's no way to prove it unless you do a head-to-head control trial, which I don't think any ethics committee anywhere in the world, in the developed world, where access to this IVIG or plasma exchange will give permission to do it.
There's one question for Matthew. Matthew, question is, how did the peduncular fibroid cause the MP syndrome in one of your cases? How did the peduncular fibroid cause the MP syndrome in one of your cases? Am I clear? He says, how did the peduncular fibroid cause the MP syndrome in one of your cases? Dr. Matthew, I think you're good. Dr. Matthew, kindly unmute.
I think Matthew is not there.
I'm there.
Okay, Matthew. I couldn't see
you. So this is a 35-year-old ophthalmologist who came from Australia, who actually was having meralgia paresthetica more so when she was lying on the right side. And so basically she had significant paresthesias, and she was investigated, and we found that. So that's why all meralgia parestheticas, we actually don't do lateral cutaneous nerve of thigh for conductions. We actually needle the vastus medialis lateralis and look for sinister meralgia paresthetica, femoral neuropathies. For this patient, when we did an MRI, CT, it showed a fibroid which is coming out. When she lies on the right side, it's pressing on the plexus. So when the plexus, when it was operated, she symptomatically improved. So what I'm trying to say is that when patients present to you like this, don't look for just meralgia paresthetica. Look for pitfalls in the diagnosis. You want to rule out any femoral neuropathy. That's basically the point I wanted to make.
There's one more question. How differentiate a suspect CIDP superimposed a diabetic retinopathy?
Pardon me?
How differentiate a suspect CIDP superimposed on diabetic peripheral neuropathy?
I think Matthew, shall I answer that question?
Yeah, you can answer.
Yeah. Now, it's sometimes very difficult. There are many overlapping features between diabetic neuropathy and then suprared CADP. But 2-3 points can help. One, it's a predominant motor involvement than the sensory. Second, acute is relatively a subacute progression. Third, proximal muscle involvement than the distal muscle involvement. And an ataxia which is out of proportion to what you usually get in diabetic neuropathy. Diabetic neuropathy, even if however severe, will not be very severely ataxic. They still can walk on with, but if you had a very severe ataxia, as you see in Miller-Fisher syndrome or something like that, then always keep that it's not a simple trait for diabetic neuropathy. So the points are, one is the CSF protein may not help very much, but it's unlike it is a very high CSF protein, more than 0.5 gram, then you can consider. Otherwise, never study is not going to help very much. Even FF latency can be prolonged in diabetes. These are the 2-3 clinical points by which you can suspect a superadded CADP on diabetes. One is the predominantly motor, relatively rapid involvement in subacute fashion, proximal involvement of motor more than the distal, and the ataxia out of proportion to, severe ataxia out of proportion to the sensory loss. These are the points by which you can suspect.
And they're usually painless also, painless proximal.
Yeah, painless proximal also.
And retrospectively, you may respond to immunotherapy.
Correct, yeah, that's it.
And here steroid also been given and shows response. There's no more question.
Yeah, you can close the session now.
Shall we conclude the session?
Yeah.
Yes, sure, sir.
Conclusion done by Dr. Nirmal.
To the organizers, we can.
Organizer. Nirmal here.
Thank you, sir. All the speakers and Dr. Vinod Puri. We conclude the session as the time is over. So we'll meet in the next month.
Thank you.
Okay, thank you all.
Bye.
Thank you, sir. Thank you.
Thank you, Matthew. Thank you, Vishnu.
Thank you, sir.
Thank you, sir.
Yeah.
Thank you, everybody, for interacting session, and we'll come back to all of you again next month. will inform you the topic and date.
Okay. Thank you, sir. Thank you.
Thank you.
Thank you, sir.